So Pallavi, start with the Vinayagar. Yeah. Then we go for the ESI prayer.
Okay. Stop sharing.
Yeah, boss.
Stop sharing. Just a minute. Just a minute. Okay.
Okay,
Yes.
just give me 1 minute.
Okay. See, once I open the session, Ganesh, you can play the prayer, Ganesh Vandan.
Yeah.
Okay.
Just let me give a good evening to everyone.
We are live now.
गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया
ॐ गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया
Okay.
Good evening. Yeah.
Let me start with the Tamil New Year greetings. Today is our Tamil New Year day. Okay, so I wish everybody who's participating as faculty as well as the delegates a very happy New Year ahead. And this is the third series of the webinar which we are conducting on behalf of Tamil Nadu Federation of Obstetric and Gynec as well as Endometriosis Society India. And this is being accredited by ICOG with 2 credit points. But I'm sorry that last webinar's credit point, we have got the list, everything. And then now we'll be sharing the ICOG credit hours certificates to all the participants soon. So from the next, from this meeting onwards, I don't think we have any difficulty because there was a teething difficulty. So on behalf of the society, I welcome Dr. P. Das Mahapatra, who is the president of Endo Society India, as well as Dr. Pradeep Mitra sir, who is the secretary for Endo Society. And I also welcome the faculties, Dr. Kanti Pansal Madam, Dr. Suranjan Sekravati, and Dr. Hemalata Pugilendi for this program. So now let me request Dr. PDM sir to give the welcome address and say something about the Endometriosis Society India, because most of them, they do not know what is our society and how much work we are doing. So I welcome Dr. Pramadesh Mahapatra and Dr. Harshini. You can introduce Dr. Sir. Unmute yourself. Unmute.
It's a very big honor to introduce Dr. Mahapatra sir. He's been an inspiration to all of us. And sir actually doesn't need any introduction. And sir is a director of Spectrum Clinic and Endoscopy Research Institute, Kolkata. He's an ex-chairman and All India Coordinating Committee, Royal College of Obstetrics and Gynecologist, London. He's an examiner for MRCOG and FRCS, is president of Endometriosis Society India, is a board member of Asian Society of Endometriosis and Adenomyosis, is a collaborator of Endometriosis Clinical and Genetical Research in India, is a vice president of Indian Endoscopy Society, is a founder president of Medical Education and Research Society of India, and he has in 24 international publications, and he's a holder of private pilot license too. We welcome you, sir.
Thank you.
It's a great honor to have you, sir.
Thank you. Now, the welcome address, I think I shared last week, last presentation. But you have to excuse me, my voice is not correct.
Do you have the recorded message? Pallavi, Pallavi, you have the recorded message of sir, no? Previously,
No,
we
let-
had,
In the previous meeting, we had it, ma'am.
Yeah.
Can you allow me some
I
time?
think, Ramani Devi, I think Dr. PDM should make this message in his own voice,
yes,
not the recorded one.
Yes,
I
yes.
want that.
yes, sir. No, I wanted that only, but PDM sir,
Yeah.
you can say few words, sir.
Dr. Dashmamitra, sir, you say something in your own voice.
It is through such regional and national synergies that we truly move the needle in women's healthcare. We all know that endometriosis is
Stop
not
the
just a
recorded
disease
message
of
and ask Dr.
tears,
Dashmamitra to say
it's a
in his
disease of reality that affects millions of women in
own
India,
voice.
often in silence. Despite our advancements,
Jignesh, I'm asking you to stop this record.
as specialists, we are no longer just treating a condition, we are managing a chronic, life-altering journey for our patients. This webinar is designed to bridge the gap between complex pathology and practical bedside management. Our goal is to move beyond the textbooks and focus on early clinical suspicion and diagnosis, precision in surgical and medical intervention, the holistic long-term care of the patient. Over the next few sessions, we will dive deep into the nuances of endometriosis. I encourage every attendee to be interactive.
Pallavi ma'am, you can stop it.
It's a serious goal and bring the most difficult cases to the fore. The ESI's mission is to empower, educate, and eradicate the stigma of this disease. By being here today, we are fulfilling that mission. I'm heartened to see such a strong pan-India representation joining a webinar hosted from the South and East. Without further ado, let us begin this journey of learning. I'm certain that the insights shared here will reflect in the improved quality of life for our patients tomorrow. Thank you, and I look forward to a robust and enlightening session.
सर आपके यहाँ से वो प्ले हो रहा है?
Ask I request Dr. Dashmamitra to say a few words in your own voice. Promoteshda, you just say a few words in your own voice, as you like.
Yes. As you heard
Yes,
by
that's it.
my presentation during the last webinar training period, I'm going to say something about the welcome address today. You see, the endometriosis is no longer a disease of theories, as we said. It is a disease of, now people call it, it is a systemic disease. It is no longer restricted to pelvis. It spreads everywhere in the body. So our thought process for treating the endometriosis in the pelvis is no longer persist. We have changed our policy to treat the patients as a whole, from pelvis to everywhere in the body. Now, I welcome everybody to participate with this seminar, or you can do online training courses organized by Tamil Nadu Federation of Obstetrics and Gynecology, along with Innovative Society India. Now, delegates from all over the India has come to join us. That is a good sign. And I also welcome Alcare division of the Olympic company, who has taken all the trouble to help us to organize these training courses. I wish all of you to be successful and look forward to be a member of the society. Thank you.
Thank you. Thank you.
Thank you
PDM
so
sir.
much, sir. I next request Dr. P.D. Mahapatra to say a few words, who is the Secretary General of the Endometriosis Society of India, Society India. Dr. Mahapatra, Pratip Kumar, go back. Dr. Pratip Kumar Mitra is the founder, Secretary General of Endo Society of India, Society India, and past president of Bengal OBGYN Society. he is working on endometriosis and adenomyosis for the past 23 years, organizing secretary of International Congress on Endometriosis 2025. And then he has 17 publications and number of books. And he's been an international faculty in FIGO, ACE conference, AOCOG, SEUD conference, and AOFOG, etc. Past faculty from University of Illinois, Chicago, USA, and past faculty of Uchida Hospital, Japan. And he is a visiting experimental endometriosis research fellow in UBC, Canada, and principal investigator of NHS and Southern Health Foundation, UK 2024 to 27. So with this, I welcome Dr. Mitra sir to say a few words about Endo Society.
Can I share the slides?
Yes, sir.
Jignesh? Is it visible? Can you see it?
Not sorry.
No, sir.
Not,
No,
sir.
no,
Hello?
no, we are not seeing.
The entire screen, then share.
Yes.
Currently, it's not started. You can click on share. Just
Yes,
wait.
yes, yes.
Just say I come, sir.
Coming?
Yes, sir. It's come.
Okay, that's
Make
fine.
it full screen, sir.
Yeah. Oh,
Hmm.
thank you,
Okay,
Dr.
sir.
Ramani Devi.
Yeah.
At the outset, I welcome this everyone in this particular course. As PDM sir has already said, it's a 6-month course, and I congratulate and express my heartfelt thanks and gratitude to Dr. Ramani Devi, convener of our ESI module and scientific chair of Endometriosis Society India, along with Dr. Malaraj and of course Dr. Harchini of this course, which would be running from March to August 2026. So it is a very nice job. Now, a few words on endometriosis, I must say today. This is a society which was born in the year 2003. And this was the brainchild of Dr. B.N. Chakraborty, the then living legend and lifelong, all the time living legend. And it was nicely implemented by the founder, Secretary General, Dr. P. Das Mahapatra. And fortunately, I was there as a Deputy Secretary General, and I had the chance to work with both of them, the stalwart and the legends, since its inception. So this is the society which is not only working on endometriosis and adenomyosis, but also in uterine disease at present. But during that time, this was the first society not only in India, but also in Southeast Asia, as I told that it was born in 2003. And Dr. BNC, Badrinath Chakraborty, is to teach us always the 4 points. Prediction and prevention of one, then strike at the root on this disease, catch the disease at the early, and publish or your work or you would perish. This is the 4 points is to tell us of it. This is the mool mantra, I would say, of our Endometriosis Society India. Coming down to the mission and vision, briefly, we all are endometriosis fighters. We thrive and to work to look into the disease in its molecular level and to implement the necessary medication or the other management for this particular disease. We aware the people, not only the people, the practitioners, general practitioners, gynecologists, everyone, for the earliest suspicion. I particularly give stress on this earliest suspicion point. We dream, this is our dream, to come to a procedure which would be able to cause near permanently management or cure of this disease. We know it is not a curable disease. Now our basic structure is there like this. Our secretariat is there in Kolkata, and our live members are nearly 800. We have 5 zonal coordinators, and in 5 zones in India, as per I usually follow the lines of Oxid, and we have several chapters. These are the chapters that you can see, this Varanasi, Muzaffarpur, Darbhanga, Jaipur, and upcoming chapters are there in Chennai, Hyderabad, Faridabad, etc. Our journey since inception, it was a very tough journey. I remember when we started the journey, everyone used to laugh at us that what the hell you are doing. My colleagues and seniors used to say that you have opened a society on a disease which is being written only in 10 pages in a textbook. We had a very tough time, and hats off to our then Secretary General and present President, Mr. PDM said. From 2003 to 2010, we used to do scientific programs and live workshop mostly in Kolkata. Then 2010 to 2022, 20, we used to give more and more stress on public awareness. The first and second international conference was held in 2015 and 2019 at Kolkata and Jaipur. And the Dream City Meet was also held at Durgapur. Then from 21 to 25, yes, we could involve rather world-class luminaries as our advisors. The third and fourth international conferences were held in 2023 and 2025 in Kolkata respectively, and the most successful first Endometriocon, conference was organized by our one of the chapters, that is Varanasi chapter, under the guidance or under the organization or of organizational capacity of Dr. Shangita Rai and Dr. Sudha Singh in the year 2023. Now, we are doing publication of quarterly journals, that is Endometriosis Update, and I must congratulate and pay my heartfelt thanks to Dr. Ruma Sinha, and now it has been taken up by Dr. T. Ramani Devi. From 2026, I rather wish to publish one historic book, The Journey of Endometriosis Society India, how much struggle we had to do to come to this level. Now, I give special emphasis on awareness from training of the adolescents. Second one, branding our Indian session everywhere in every part of the globe as ASI session, and which has been done as Asian Conference in Endometriosis in 2 consecutive occasions in Manila and Philippines and Bali, Indonesia, respectively. We have become an integral part of Society of Endometriosis and Uterine conferences, and for the last 5 and 6 years, and Dr. Padul is instrumental for this initiative, and we have become a part and parcel of that particular conference in that particular European conference. And lastly, we are arranging training for our faculties and our members in a world-class endometriosis lab in USA and Canada, and it has become possible. Now we are doing also various researches. Some of them I can see over here. We are Mary project, Plato project, and one LME project is running, and many other things are running. And these are the assistant or associated researchers and co-investigators. Dr. Ramani Devi is here, and although I am there as the principal investigator. And then academic activities of ESI. Well, this was my dream for a long time, and now quite a few publications have come up, particularly in various international journals, in the name of ESI, where name of ESI is there, unlike past. Then our Foxy ICOG program, a 3D teaching series, had been done from 24 to 26 in the month of February this year. And then I just talked about right now, our 4 members had been invited as a faculty at Frankfurt in the CUT conference 2026, namely Dr. Parul, Dr. Ramani Devi, Dr. Devesh Shukla, and myself. Then our Jaipur chapter is coming up with a 6 months webinar from April 2026. And this is some of the pictures of Frankfurt conference. As you can see, Dr. Ramani Devi with Dr. Shafran is one of the stalwarts of endometriosis globally. And then you can see this is my presentation. Dr. Shukla, Dr. Thomas is there from France, and all the team who were present over there, and Dr. Paul, of course, the leader was there. Coming down to the public awareness programs, yes. This time, I had requested all the members of our society to do at least 2 public awareness programs in the month of March, and not only in the March, but also in the entire year. Many of the reports are coming. This Darbhanga Society was very much instrumental in this aspect. Dr. Bharat Prasad took a lot of initiative in this program. You can see some of the pictures. And then Dr. Ramani Devi also did quite a few programs. Dr. Asha Rao said some reports. Dr. Prachi did something, quite a few programs. Dr. Sangita Rai did one program. And our Kolkata coordinator from ESI, Khorda Manon Welfare Society, did some of the programs in this month. Then one endo update is coming up. The Ramani Devi is instrumental in this particular endo update, and these are the various articles which will be coming up in this endo update, which will be published very soon. And then upcoming academic activities. This is very important. We're going to have this endometriotic 360 conference in the month of June 2021 in this year, and this where we are there as one of the important part, along with IAGE, OGSSI, and IAGE Tamil Nadu chapter, and Dr. Malaraj is very much instrumental in this particular conference. Along with that, there will be another conference, another rather one-day on endometriosis program under the guidance of, under the leadership, or rather I should say, Dr. T. Ramani Devi in the South Zone. The day will be finalized very soon in the month of May, as I already said. Now, at the end, I wholeheartedly request every member of our fraternity who are not yet a member to join Endometriosis Society India as a life member. Why? To promote endometriosis awareness on one side, and to fight against endometriosis and speak on endo to adolescent girls. I acknowledge Alcare and Alembic as my president has already acknowledged, and also I declared that all gynecologists and members of our fraternity, not only in India but across the globe, would be invited to join this webinar for the next 6 months. Of course, we have done already 2. Then 2 credit points, and would be given to all the participants who would be joining this particular seminar, and the course completion certificate will be given to all of them at the end of this course. And I acknowledge particularly my indebtedness to President and Secretary of Tamil Nadu Federation of OBGYN for getting this credit points and other formalities. I am very much thankful to them. These are my special thanks. I wish this is not only a grand success, but it would be a very, very grand success. And this is our website, as you can see at the bottom of the slide, and you can see all the details of our activities in that. This website. Now, coming down to the ESI anthem, actually, we have not exclusively our own anthem as of now, but one time-old anthem which my president loves and I also love, which we often play at the end of our conferences. And I request Jignesh to do the honors to play that song. Thank you very much for hearing me. Thank you.
Jignesh, I will play the anthem. Sir, can you please stop sharing?
Yeah. Thank you.
Yes.
Ma'am, stop sharing and select the share sound.
Sorry, Jignesh?
Stop sharing. At the time of share, you select the share sound button.
Share, but I can hear this.
You can hear, but we can't.
The volume is not probably adequate.
Okay. So should I do a share? Okay,
Share.
sound. Got it.
Yeah.
I started once.
We shall overcome. We shall overcome. We shall overcome someday. Oh, deep in my heart, I do believe we shall overcome someday. We shall overcome. We
Thank you, sir, for the song by Endometriosis Society India. Now, shall we move on to the scientific session? I welcome
Yes, definitely.
Dr. Harshini to share the CV of Dr. Hemalata Pugalenthi.
Ma'am, I have shared.
Yeah. Harshini, you can introduce.
I feel very honored to introduce Dr. Hemalata Pugalenthi ma'am. She's working in, she's a consultant obstetrician and gynecologist at Bihar Multi-Specialty Hospital, Chennai. She's a gynec laparoscopic surgeon, endometriosis surgeon, fertility specialist, cosmetic gynecologist. She's graduated from Tanjore Medical College and she's done her MD from KMC Mangalore University. She's done her diploma in gynec laparoscopy, University of Kiel and Gießen. Certified advanced endometriosis excision surgery with neuropelviology. She's done her training from IFEM, Bordeaux, France, and she's done her advanced retroperitoneal dissection by Dr. Sailesh Puntampekar. Endometriosis excision course by Dr. Sanjay Patel, Mayflower Hospital, and special interest is minimally invasive endometriosis excision surgery. We welcome you, ma'am.
Thank you so much for the warm welcome. Sorry for my throat. I've been having pharyngitis. Good evening, everybody. Respected faculties, distinguished speakers, and dear colleagues. It's my privilege and honor to chair this session, focusing on a topic that continues to challenge us both clinically and emotionally. Endometriosis. It is far more than a gynecological condition. It is a chronic, often debilitating disease that affects a woman's physical health, mental well-being, fertility, and quality of life. Today's session brings into focus the critical pillars in the management of this condition, medical management of endometriosis, non-hormonal and alternative tips of endometriosis, MRI in endometriosis, and newer drugs in management of endometriosis. I am confident that today's esteemed speakers will enlighten us with their expertise, share practical insights, and help us refine our approach to manage this complex disease. As clinicians, our challenge is to integrate these modalities effectively, choosing the right treatment for the right patient at the right time. Thank you very much and welcome you all to this academic session. I welcome the first speaker of the session, Dr. Kanti Bansal. We all know the medical management remains the cornerstone of therapy, particularly for pain control and disease suppression. Our goal is clear. It is to reduce the estrogenic stimulation, suppress the lesion activity, alleviate pain, and improve the quality of life. I welcome Dr. Kanti Bansal, ma'am, for enlightening us with the topic of medical management of endometriosis. Ma'am, over to you.
Thank you so much, Dr. Hemalata. And special thanks to my dear friend, Dr. Ramani, our respected Tasma Patra sir, and also Pradeep Mitra sir. Yeah. Can I share my... Are you able to hear me?
Yes, madam. Yes.
Yes,
Make it full screen. Make it full screen.
It is full only.
No, yep.
No.
It is full screen.
No.
I am seeing it as full screen.
Okay.
Are you seeing Dr. Hemalata as full screen?
No, ma'am.
How come?
Madam, go to slideshow and start from current slide, madam. Go to slideshow. Want to, probably you share it again, it will come. Share again.
Just a minute. Huh? I'll share now. Yeah.
Still the same, ma'am.
Yes.
No. Now I'm going to do
Click
it.
that. Click that.
Okay. Now can you see?
No.
No, ma'am.
No.
Why
Not
is
it.
it? Because
Ma'am,
I
just-
can see
ma'am.
the full screen.
Ma'am, just stop the sharing and select what you share.
I think it should be the slideshow which has to be selected, ma'am.
Yeah.
Just a minute. Stop.
Stop share. Now make it in a slide slow,
Ah,
then select it.
No, I am going to share.
No, just first make slide slow.
Okay. Just a
slideshow and
minute.
then share, ma'am.
Now can you see?
No, it's
It
not
will
starting
come.
in it.
We are seeing you, ma'am.
I lost.
Just now share, ma'am.
Just a minute. Something is wrong now. Totally. Yeah. So slideshow. Can you hear me?
Yes, ma'am.
Yes, madam.
Yes, ma'am.
Slideshow. And then I'm doing from beginning. Is it correct?
Name.
No, but you
What
start
share, ma'am.
sharing your PPT, madam. It is not seen.
Now you share, ma'am. Make it slide slow, then share.
Now can you see?
No.
No.
No, you shared it again. You share. You click on
Ma'am,
share.
click on the tab.
I don't know what's the so I go from the top, right?
No.
From beginning.
Yes. Your thing is not shared, madam. Your PPT is not seen. Close everything and then start sharing.
I have closed it now.
Start sharing now.
And select the first option. Don't select the PPT, entire screen. Select the entire screen.
Slideshow.
Hmm.
From beginning.
Ma'am, first you share.
Share is from below, right?
Yes.
No, not window, entire screen. You see, first option is the entire screen.
It says from beginning, current, and all that.
Ma'am, come in a Zoom. Don't see anywhere. Just come in a Zoom.
Yeah.
Okay. You see all the peoples, all the doctors, ma'am. You can see all the doctors. Just come in a Zoom. Forget everything and try to share. Just only share. Click on a share button.
Just a minute. Share. I am not able to see here.
At the bottom you can see.
It's in the below.
Madam,
Yeah.
did you select slideshow?
Slideshow is there below. Shall I select it?
Yes, ma'am.
Ma'am, you can select the slideshow, but the problem is that you are not sharing anything.
Ma'am, share screen will be there, no, ma'am?
I don't know why this problem is today. See, it is on the slideshow.
Can't
I'll-
see there
Share, ma'am.
is a green thing is there.
Ma'am,
You
just
see-
click on Alter and Tab once and come in a Zoom.
Now can you see?
No, ma'am.
What's the problem?
Just start sharing. It's not sharing here. It's not shared yet.
Just a minute. Where is the sharing thing? I'm not able to see it only.
I think you did it earlier, no, ma'am. The same thing, no?
Earlier, Now can you see?
No, ma'am.
Let me go here. Yeah, down, there is normal and slide sorter and slideshow. Otherwise, nothing is coming here.
Ma'am, you see there is a one video over there in a floating type. You see Zoom's video. Just first come in a Zoom. Don't close the presentation. Everything closed. Just open the Zoom. Just open.
There is Zoom.
Yes, just click on it and maximize it. Don't see anything.
Later. Now I have done that maximum.
Yeah. Okay, maximize. Now click on a share button.
Yeah, that only I did. Share.
No, it's not currently done. Just click on a share button and select the entire screen, not any window. Application window is not selected. Entire screen, the first option will be the entire screen. Just select.
Wait. So now down there is share. Okay.
Click it.
Yeah.
Wait.
Yes, ma'am.
Yes. Now
Yes.
the presentation.
Yes, press that.
This is the presentation on my
Yes,
desktop.
click on that. Click on that, madam.
Just click on it. Yeah.
Ah.
Now,
Yes, ma'am.
now click on it.
Yeah.
Now it's correct.
I'll do from beginning, right?
Yeah,
Yes.
correct.
Ah.
Can you see?
Yeah, fine.
Yeah, it's okay.
That is fine. Good.
Yes, ma'am.
Good.
Last.
Excellent.
Just a minute.
Yes, ma'am.
Yeah, so I'm so sorry for this initial hitch, but I really thank the organizing committee, both from the Tamil Nadu Federation of Obstetrics and Gynecology and our own Endometriosis Society of India. So it's a very important topic that I have been given. That is the medical management of endometriosis. I see in this era there are many surgeons doing a lot of endoscopic surgery and robotic surgery, all that. But the main problem is that suddenly, doing a surgical method may not be very proper in most of the cases. And I strongly feel that medical management is very important. I'm very conservative, so I think I like medical management. Now we have to understand what is really endometriosis. There are three distinct forms: peritoneal, ovarian, and rectovaginal. And there are four types: superficial peritoneal region, endometrioma, and also, and what are the postulated origins? Retrograde menstruation, coelomatic metaplasia, lymphatic and vascular metaplasia. Now, what is the prevalence? Around 10% of women of the reproductive age are afflicted by endometriosis, and there are 247 million women globally. That's a huge number. And then 42 million women in India. So it gives us a thought that how important it is to do the right type of management for all these patients. So incidence of endometriosis in Indian population range from 34% to 48% when we diagnose it by laparoscopy. So it accounts for as large as 50 to 60% of pelvic pain cases. And it also accounts for about 50% of infertility cases. Now, definitive diagnosis by histopathology, and there are actually no proper serum markers as yet for diagnosis. CA-125 levels can be elevated, but we have to remember it has a very limited clinical utility. Imaging studies like USG, CT, MRI are helpful. So what is very important for this endometriosis to grow is the constant supply of estrogen. And so that will be very crucial for growth and persistence of endometrial implants. We need to know this to give medical management. And also we need to know the pathophysiology, that is increased production of estradiol, increased intrinsic aromatase activity, increased production of the inflammatory markers, and also we have progesterone resistance. It's not only estrogen increase, but also the other side of progesterone resistance. Now, management are three different groups, we can say. One is the symptomatic, where we have NSAIDs, aromatase inhibitors, paracetamol, opioids, and antidepressants. Then we have hormonal. Here we have the estrogen, progesterone, that is the combined OC pills, which most of the doctors prescribe. And we also have low dose estrogen, progestin. Then came the era of Dynogest, which was used in a big way. We also have dydrogesterone, which is supposed to be good. And for a poor country like India, LNG US has a big way to go. And then we also have mifepristone and GnRH analogs, that is the agonist, and now we also have antagonists. And the surgical, we have diathermy, laser vaporization, excision, ovarian cystectomy, and presacral neurectomy. Now, coming to the drug category and drugs and mechanism, we have NSAIDs. In this, we have ibuprofen and naproxen, and the mechanism of action is reversibly inhibits COX-1 and COX-2, and that decreases the prostaglandin formation and also gastro. But the side effects are GI problems, ulcers in the gastrointestinal tract, edema, and renal impairment. Now coming to the combined estrogen progesterone contraceptive, once again, ethinyl estradiol combined with norethindrone, norgestrel, levonorgestrel, and drenogestrel. How does it act? Inhibits FSH and LH. So we have to remember in the medical management that inhibiting FSH and LH is very important. Decreases cell proliferation and enhances endometrial apoptosis. Side effects: nausea, vomiting, breast tenderness, weight gain, acne, depression, breakthrough bleeding, thromboembolism, increased risk of developing estrogen-dependent cancers. Then we have only progesterone preparation, norethindrone, medroxyprogesterone, levonorgestrel, and then how it also inhibits FSH and LH. Here also we have weight gains, the same things: acne, breast tenderness, depression, etc. Then we have the GnRH agonists, where we have even here this suppression of LH and FSH, and then the same hot flushes. You know what happens when the LH and FSH is suppressed? All the hot flushes, vaginal atrophy, etc., are there. And last but not the least, now we have GnRH antagonist, which I'll come to you all a little later. Now, when we have women with endometriosis and pain, what is the medical management? First of all, we have to understand, does this woman wants to have conception, desire for having a baby or not? If she wants a baby, yes, then we have to straight away go for our fertility treatment. Yes, not immediately, then first line is COCs or POPs or progestins. Second line is GnRH agonist. These days I'm also giving antagonists. And then if there's a recurrence, then again the same thing. Conservative surgery is still indicated if the symptoms persist or adverse effects are there. And if the patient says, no, I am done with my conception, or I don't want to conceive anymore, not now nor ever, then first line is COCs, POPs or progestin. Second line is GnRH agonist or antagonist. And symptoms persistent or adverse effects, then we go for surgery, conservative or definitive. Now hormonal treatment, the first line. OC pills, the age-old treatment that we all have been giving. Earlier, when I did my post-graduation in gynecology, we hardly knew about endometriosis. We were not taught about endometriosis. Everything I learned after I started my practice, it's so different. We just knew that something there's like endometriosis, not it was, prolapse and these things were more common. So, but we have to go on evaluate, getting knowledge by just reading or getting, attending these types of continued medical education programs, which Dr. Ramani and Dr. Das Mahapatra and Mitra sir is doing. So 2/3 of the women respond to estroprogestins. That's a real good thing, So, but there are some bothersome side effects like weight gain, mood swings, irregular uterine bleeding, increased risk of venous or arterial embolism. Reduction in lesion volume is not predictable and not significant in the vast majority of cases. Recently, I have done a research where we had taken the pain score and the lesion decrease score. So then I understood that how important is this decrease in the lesion when we give medical management. We have to remember that, and every time you need to measure the lesion. So limited long-term efficacy. We can't give them for medical management. We have to be very careful. Give for sometimes, maybe you can stop for sometimes and again restart. So due to progesterone resistance, 33% are poor responders, and the percentage is higher in women with deep nodular endometriosis. So dear friends, I'm not saying that all patients are good for medical management. There's definitely there's role of surgical management with some of the indications where we should go and do surgery first and then again put them on medical management most probably. So selective progesterone receptor modulators, SPRMs, induce progesterone modulator associated endometrial changes in ectopic foci and their efficacy is limited. Now, are hormone therapies effective for painful symptoms associated with endometriosis? We have these recommendations. So it is recommended to prescribe women a combined hormonal contraceptive. It could be oral, vaginal ring, or transdermal to reduce endometriosis associated dyspareunia, dysmenorrhea, and non-menstrual pain. And this has strong recommendation. You can see here. Now, women suffering from endometriosis associated dysmenorrhea can be offered the continuous use of a combined hormonal contraceptive pill. This one has a weak recommendation. Now, it is recommended to prescribe women a levonorgestrel releasing intrauterine system or an estrogen releasing subdermal implant for endometriosis associated pain. This one has a strong recommendation. So we can see that in a poor country like India, LNG IUS really has a role to play, and it also has a strong recommendation. Now, what are the goals of optimal medical management? So partial suppression of E2 within 30 to 60 picogram per ml would be the optimal compromise between efficacy, tolerance, and safety. Improvement of symptoms, mainly pain resulting from inflammatory endometriotic lesions, should be the main goal of long treatment. Coming to the second line of management, that is the GnRH agonist, leuprolin, goserelin, and triptorelin. Delayed therapeutic impact. Why? Because there's a flare-up effect. When we know that whenever we give this GnRH agonist, there is a flare-up of the FSH resulting in increased estrogen, and so this flare-up effect we do not like it. Now, excessive suppression of estrogen to less than 20 picogram will give hypoestrogenic adverse effects. We don't even want that. So, inability to titrate E2 levels is the problem here. Unpredictable reversibility of treatment when injectable depot forms of GnRH agonists are used. So that was one reason where I was very hesitant to use the GnRH injectables to my patients, because we never know how much, when it is going to release. I used to be always a little bit suspicious. I don't know whether it was good or bad, but I used to not like to give it to my patients. Now, treatment duration is limited by flare-ups, hypoestrogenic adverse events, including hot flashes, etc. Continuing with the hormonal treatment, clinicians should consider prescribing combined hormonal add-back therapy alongside GnRH agonist therapy to prevent bone loss and hypoestrogenic symptoms. So I need not go into the detail of add-back therapy. We add a little bit of estrogen, progesterone in these patients and they do fine. So this has a strong recommendation. And in women with endometriosis associated pain refractory to other medical or surgical treatment, it is recommended to prescribe aromatase inhibitors as they reduce endometriosis associated pain. Aromatase inhibitors may be prescribed in combination with oral contraceptives, progestins, GnRH agonist, or GnRH antagonist. So I think this is really good, and this has a strong recommendation. Coming to the aromatase inhibitors, aromatase P450, this is the key enzyme for ovarian estrogen biosynthesis and catalyzes the conversion of androstenedione and testosterone produced in the ovarian theca cells to estrone and estradiol in the ovarian granulosa cells. Evidence demonstrates that the endometric lesions express aromatase and can synthesize their own E2. Aromatase inhibitors first used for the treatment of postmenopausal estrogen receptor positive advances. Now, the prospective cohort study assessed the impact of 3 months of letrozole 5 milligrams per day. This is the aromatase inhibition, together with progesterone add back on ovarian endometrial size and symptoms. This was by Agarwal and Foster in 2015. And this study compared the size of 14 endometriomas in 8 consecutive women before and after treatment. The mean endometrioma diameter decreased 50% from 4.6 to 2.3. But I think the size of the study was less in this. The study also reported a reduction in patient reported with symptom endpoints of the Baber-Golo and Herman scale, with mean dyspareunia score decreasing from 2 to 0. And also there was improvement in the dyspareunia non-menstrual pain. Now, aromatase inhibitors letrozole, the mechanism of action, I won't go in much into the detail. What it does is it acts by inhibiting the aromatase enzyme, which converts androgens into estrogens in peripheral tissues and within endometriotic lesions themselves. In endometriosis, aberrant expressions of aromatase in ectopic endometrial tissue allows local estrogen biosynthesis supporting lesion growth. Letrozole inhibits thus local estrogen production, helping to shrink lesions and reduce symptoms. Now, this is the ISHRE endometriosis guideline development group, and they say in women with endometriosis associated pain refractory to other medical or surgical treatment, it is recommended to prescribe aromatase inhibitors because they reduce endometriosis associated pain, and aromatase inhibitors may be prescribed in combination with oral contraceptive, progestogens, GnR agonist, or GnRH antagonist. Just to give a little bit of my personal choice, I did give letrozole in some of my patients where I used to give other molecules, and I found that it was quite a good improvement in endometriotic lesions. Now, what about the antagonist? Is the ideal now it's come way back. These oral GnRH antagonists are oral short-acting treatments for endometriosis-associated pain, and the way they work is by competitive blockage of the GnRH receptor, dose-dependent suppression of FSH and LH production, inhibit secretion of ovarian steroid. So main advantages of GnRH antagonist, there is no flare-up effect that we see with the agonist, and also dose-dependent estrogen suppression from partial suppression at lower dose to almost full suppression at higher doses. There's rapid reversibility and recovery of hormone secretion after stopping treatment. Actually, we have done a real-world study of antagonist, giving them in cases of endometriosis. Actually, I was told to select 3 more, doctors who are doing very good work in endometriosis from other zones. So I had Dr. Ramani Devi from South, and one from North and one from East. Unfortunately, some of from East, there are not too many people doing this work. And anyway, we did a lot of cases and we found that definitely antagonist is a very good molecule, and there are hardly any side effects with the antagonist. Of course, we have done the study for 3 months, and I actually presented it in the ICOG this time, but I wish Ramani and all my other colleagues, we do more than 50 cases in the next few months and present it again, maybe in Calcutta, if Dr. Dasma Patra allows us. So competitive blockage of GnRH receptor is there, dose-dependent suppression of FSH and LH production, and then inhibit secretion of ovarian steroid hormones. Main advantages of GnRH antagonists: immediate gonadotropin suppression. There's no flare-up. I told you this. Dose-dependent estrogen suppression, from partial suppression at lower dose to full suppression at higher doses. The best part of this molecule is there's a reversibility and recovery of hormone secretion after stopping treatment. Now, once again, this is the endometriosis guideline. Yeah, so diagnosis of endometriosis, laparoscopy is no longer diagnostic gold standard, and it is now only recommended in patients with negative imaging results where empirical treatment was unsuccessful or inappropriate. These days, we also think that giving 1 month of medical treatment, maybe GnRH agonist or antagonist or Dynogest, and if the pain and all the symptoms stop, that also we can diagnose it's a case of endometriosis. So medicine has gone way above. Now, treatment of endometriosis associated pain, GnRH antagonist treatment support their uses as additional. That is a second line treatment option. Recent data indicate that post-operative medical treatment may be beneficial towards pain management. We've never used danazol and all those molecules because later on we just stopped danazol. It was there earlier, but because of its side effects. For the treatment of endometriosis associated infertility, I think we have to have extended medical management with this either agonist or antagonist, and then take up these patients for infertility management. And I think with the advent of all these molecules, now we may not really opt for surgery until and unless there's a big endometrioma or maybe rectal node or causing too much of pain. Maybe we should opt for medical management. Now we have so many of these elagolics, rilugolics, and so many other things. I think let's not go into this. And elagolics and rilugolics have been approved for endometriosis by the FDA, and these lisagolics now trials are going on. Now, antagonist action again inhibits FSH and LH, reduces E2 progesterone. So, estrogen suppression reduces the growth and survival of endometriotic lesions, decreases inflammation and dual suppression. And progesterone and additional anti-inflammatory effect is also is said. We'll have to look into it a little more later on. Now, progesterone suppression, atrophy of ectopic endometrium, decreases inflammation, promotes apoptosis in endometriotic cells. Now, Dynogest. I will not go into Dynogest because we all have been studying this from a long, long time. Do I have some time? Hemlata?
Madam, you take another 3 to 4 minutes, madam. Make it fast.
Okay. So Dynogest, I'll not go into the depth because we've been using it. So it is the only progestin that combines both properties of 19 norprogestins and progesterone derivatives. How does it act? In ectopic endometrium by decreasing cell proliferation, improving cell differentiation, and decreasing bleeding and uterine contractions. Indications, it is in a tablet form, so anybody, people can take it very easily, even in adolescents can take, and it can be used for endometriomas. Here I say that Dynogest can be combined with other molecules. These be combined with as I told you, letrozole and all. It has a more effect if it is combined with other molecules, and the endometriomas shrink. Prevention of recurrence after surgery, that's a good indication. And extragenital endometriosis like bladder, colon, and scar, adenomyosis, and prior to IVF. I can say for adenomyosis, I don't know why, but I have a lot of cases of adenomyosis in Gujarat. And for these adenomyosis, I found that these antagonists have a good effect on the adenomyosis. After giving 3 months, many of the patients, as it gets washed out. The effect is so good. Now, Dynogest dosage is 2 milligram, and this reduces up to 70 to 80% of the pelvic pain that it can, and Dynogest can be used for a long term. So this is also a long-term. This is the Visana study. I think all of you know. Safety in adolescents is quite safe. That's what they say. They did the study in 12 to 18 years of girls. This 72 this Visado studies, they say that 78% of the adolescent girls were free of symptoms at the end of 52 weeks, whereas VAS score decreased from 70 to 9. That's very incredible. 84% of adolescent girls were very much satisfied, and minimal reduction in BMD. So BMD reduction is not severe as Dinogests maintains the estrogen threshold unlike GnRH agonists. In GnRH agonists, we know that this is a problem. So in adults, again, Dinogests can be given. It is quite safe, Dinogests compared to the Danazol. And what about comparison of Dinogest and antagonist? Antagonist again causes a bit of bone density loss, and antagonist cannot be given to adolescents. Dinogest scores in the above two cases, and there's a gold standard. Actually, antagonists are now, we can give it orally. That is one thing, and they do for the adults. I think antagonists act well. Dinogest scores as far as BMD is concerned. Now, there's one product which I have used, and I want to just throw a little light because it is not the regular allopathic drug, but it is a nutraceutical supplement in endometriosis, and it reduces the oxidative stress, and which is caused by estrogen micronutrient deficiency. It is corrected, and it has a lot of role because I've given not as a single treatment of this supplement, but along with say Dinogest, along with say antagonist or agonist, I have given this supplement because there's, as I thought this, the pain and the problems that they have, I thought no, there's no worry if you give this nutraceutical supplement. And to my surprise, the patients asked me, give that powder, it's quite good, we feel comfortable. Even after operation, one of my patients had sent to Sanjay Patel, my relative, my cousin, and he operated very well, everything. But then afterwards, she had pain, some nerve pain, and he was not able to do anything about it. I gave her again some molecules, and it was, and then I gave her the supplement. She was little better with this. I don't know how it really acts. We are all scientists, right? But then it acts. Nutraceuticals, I think, are in vogue now. So estrogen metabolism, I think it acts on the estrogen metabolism pathway. This is known as a android, and which has hormone balancing, Shatravari, Ashwagandha, antioxidants, and all that. They control the estrogen metabolism and also detox by the excretions of all these toxics. I already told you it balances the hormones, neutralizes harmful metabolites, etc. I'll not go into this. I think I'll not also go into endometriosis and pregnancy because I've stopped doing obstetrics from nearly 20 years now. Recurrent endometriosis is important. There's actually sort of no medical management, I think. So here you can see the end point is surgical management. The end point, infertility, pain, ART, cryopreservation, end point surgical management. So I think the surgeons will be very happy that in recurrent endometriosis, we are again sending our patients to the surgeons. If patient desires fertility, then individualized approach, that's what we do. We try without the surgery initially, and then we do down regulated FET, etc. If it doesn't turn positive, then again we send them to Dr. Das Mahapatra. So take-home message, management of endometriosis in the reproductive age group requires an organized and multifaceted approach, which includes various therapies like medical, surgical, and ART. I think, first of all, we should have it in mind that we should not have any preconceived ideas. Okay, this patient is having pain, this must be that and this. No, have a very clear mind, go systematically. Just suddenly don't go and do a PV, do a transvaginal sonography, do a proper clinical examination. And before that, a proper history. In history only you can make out that this patient has endometriosis. Okay, congestive dysmenorrhea, done. The half of your diagnosis is there, and she may be having adenomyosis. So things become, so go very systematically, take a proper history, do a proper examination, no shortcuts, and then once you clinch the diagnosis, treatment becomes very easy. So such treatments become essential in reducing the negative impacts caused by the endometriosis and aim in achieving overall fertility and pain. By seeking expert advice and implementing correct plan of action, endometriosis can be effectively managed so that there's pain relief and improvement of fertility. Adequate choice should be made in accordance with the patient's age, disease severity, and desire to preserve fertility. So, my dear friends, thank you so much. I think you've been very, very patient with me because of the starting problem of the slideshow, and also a lengthy talk. Thank you so much, Dr. Ramani Devi. Sir, Das Mahapatra sir, thank you for being and listening to my talk. I really respect you so much. Yeah.
Thank you, ma'am, for emphasizing the role of medical management in endometriosis, the various drugs which are used. But I cannot be emphasizing again and again that medical management plays a major role in case of pain and also to improve the quality of life of a patient with endometriosis. There is no, I think that I am sure that there is no role for medical management if the patient wants to become pregnant. And pre-surgical medical management, it is recommended only in cases where they are going to buy some time. Like if some, urgent or emergency situation is there, they cannot undergo surgery. And similarly, post-surgical, there is definitely a role for medical management to improve the quality of the pain outcome following surgery for the better quality of life. Thank you, ma'am, once again
So,
for the clarity of thought.
Madam, it was an excellent talk, but I would like to add few more points. That is, in the recent Sud conference, they were talking so much about the antagonists, but they are in favor of relugolix. Because what they say is relugolix has got a built-in add-back therapy so that it can reduce the side effects. So that was their only argument. But I personally feel in our situation, we are using a lot of elagolix. The advantage of elagolix is it is dose dependent and we can adjust the dose for a severe disease like deep infiltrative endometriosis. We can go up with 200 milligram BID.
Yeah, I just
when the pressure, when the pain drops, you can reduce the dose and you can maintain it for beyond up to 2 years. It is quite safe. Then regarding the recurrent endometriosis, again, I would prefer better to follow the patients on medical management. That should be the first line. And if they are not responding to that, then ultimately it should be one surgery, which is going to be the ultimate. So
Dr. Ramani, Dr. Ramani, I think relugolix is also antagonist, but it has a little bit of estrogen.
Yeah, estrogen. That is
and then I think there's a study
1 milligram and 0.5 milligram of ethylene.
And there's a study of 5 years also for that.
Yes.
2 years is
so
there, but
people in Europe are using only relugolix and they have started using ensaigolix also. There have been this 1 trial and 2 trial, and I think elagolix is taking a backseat. Then one more thing about the non-hormonal part is, now we have a combination of palmitoyl ethanolamine because they say it is the mast cells that has to be suppressed because it releases pro-inflammatory cytokines. Okay, so palmitoyl ethanolamine is one drug which can reduce the release of this and pro-inflammatory substances from the mast cell. Then again, they have combined it with N-acetylcysteine, which is a pro-anti-inflammatory factor. Plus, they have added magnesium in there. magnesium is one of the important agents for pelvic relaxation, because all these endometriotic patients, when you do the PV, we know that all the pelvic floor muscles are all tight. So the muscle relaxation activity is there. So this drug is also as an adjuvant, you can give it along with the regular drugs. So thank you so much for your very good presentation.
Dr. Ramani, I just wanted to tell you about magnesium. What you said is very true. Now magnesium has become the on-the-counter medicine. Everybody is taking magnesium. I agree with you that it causes a little bit of relaxation, and so people are finding it, and even for muscle cramps and all that, they're just popping magnesium these days. It is a pleasure always to come to your webinars and speak here, and your conferences in Trichy. I really love it. Thank you. We learn a lot, Dr. Ramani.
Thank you, madam. So, Hemalata, next, go ahead with the next speaker.
The topic.
Pallavi, show the top, show the CV of Archana.
The next topic is non-hormonal and alternative therapies of endometriosis. We invite Dr. Archana Devi for the presentation. We all know that this is a chronic inflammatory and a pain-driven condition. So we need pain modulation beyond hormones, nutrition as therapy, and physical therapy and pelvic floor rehabilitation, mind-body interventions, alternative and complementary therapies, lifestyle medicine, patient empowerment and support is mandatory, I feel. So we invite Dr. Archana Devi for her presentation. Over to you, ma'am.
Good evening, ma'am. Thank you, ma'am, for giving me this opportunity. I thank the organizers. Nice to see Kanti, ma'am. Nice to see my mother after 1 week. I'm not seeing her. And thank you, sir, for giving this opportunity. So shall I share my slide?
Yes.
Is my slide visible?
Yes, yes.
Yes, ma'am.
Yeah, thank you. So my topic for today is non-hormonal and alternative medical tips in management of endometriosis.
Archana, slightly increase your voice. Voice is low.
Okay. Just 1 second. Let me. Is my voice okay now?
Yes.
Yes, thank you. So starting with the endometriosis, as we are discussing, that we all understand it is a chronic disease. That means the patient once has endometriosis, lifelong patient of endometriosis, and they have to go through so many things like pain, irregular cycles, repeated surgeries, on and off hormonal therapies, prolonged treatment, follow-up. And in spite of that, there is also a very increased chances of having a recurrence, which is the sad part. And these patients are always chronically depressed, and they would have gone to multiple doctors, tried multiple treatments, and maybe in spite of surgery also sometimes the patient has recurrence of disease, which is the very difficult for the patient to go through this whole process. So hence the need for adjuvant treatment, that in terms of a non-medical or alternative management therapies, because these therapies can be added as adjuvant and to a primary treatment, let it be a medical management or let it be a surgery, let it be a hormonal treatment, whatever it is, addition of this non-medical management can help to reduce pain, decrease the inflammatory response and things like this, which will help the patient in her symptomatic problems. So we all understand there are the traditional treatment methods like surgery, painkillers, hormonal therapy. But what is new is use of all other therapies like the physical therapies, acupunctures, regular exercise, use of antioxidant like herbal things like turmeric, ginger, massage, vitamin D, magnesium, prebiotic, probiotic. These all other adjuvant therapies are catching up because addition of these therapies is again, having some kind of effect in this patient. So in terms of symptomatic pain relief. So looking at let's see what does the evidence says about all this treatment. So we all know the basic pathophysiology of endometriosis. I'm not going into detail of that, but what I want to highlight here is the molecular and cellular alterations which happens, and also the increased inflammatory response and increased invasiveness and vascularization of the lesion, which actually leads to the primary pain in these patients with endometriosis. So what are the alternative treatment options which we are looking at? Is prime and first we have to stress upon lifestyle modification. It should be one of the the first thing which should be emphasized to the patient. How important for her is to take the hormonal treatment. It is as important for her to follow some basic lifestyle modifications, and addition of some natural and complementary therapies, non-hormonal medications, if some surgical or minimally invasive surgical managements, and other emerging new techniques. These are some of the evidence which we are going to see in this presentation. So starting with the treatment, lifestyle modification, and what are the other therapies? We usually start with the diet. So nowadays, a lot of medias are focusing on anti-inflammatory diet, not only in terms of endometriosis, but also helps to reduce other chronic diseases. So anti-inflammatory diet, you have to tell her what is anti-inflammatory diet, how much she has to consume. So better to put a consultation with the dietitian, and optimizing her weight, and all these things will help to reduce pain. And addition of antioxidants in terms of in the diet, as well as even antioxidants can be supplemented along with the hormonal therapies as a prescribed medication. And we have to advise her to use a lot of high fiber diet, and of course addition of vitamin D, iron supplements, as ma'am, magnesium, use of magnesium, all these things can be used as a primary treatment. I mean the adjuvant supplements. And she has to avoid a diet which aggravates the symptoms, especially patients with endometriosis. They are little allergic. I don't say they're allergic, but certain diet can increase the symptoms of pain, especially the red meat, where they face a lot of constipation. This invariably increases the pain during her periods, and pain during defecation, and all these things can lead to certain problems. So she has to herself identify what she is, which diet is suitable for her, and a customized diet plan will always help in this patient. And coming to the physical activities, these patients has to be encouraged to be more physically active, and they have to focus a lot on pelvic floor exercises, because they can cause a good relaxation of muscles, which will lead to decrease in pain. And use of electrophysical agents, that is cold and warm compression, electrical therapies like neuromuscular stimulation, transcutaneous electrical nerve, we call it as TENS, and also pulsed high intensity laser therapies can be used as adjuvant treatment if the patient has severe pain. And of course, these patients have to have a mind and body technique. They have to practice some kind of cognitive behavioral therapy, which will help to manage the stress, and relaxation exercises, breathing exercises, mindfulness of education. And it should be a continuous, a day-to-day process in their whole in their basic lifestyle. It should be included in their basic lifestyle. Now coming to the diet, we all know folic acid, vitamin B6, methionine, these all are very rich in fruits and vegetables, all vitamin A, E, C, and omega-3. So we have to encourage the patient to take a lot of fruits and veggies compared to meat. And polyunsaturated fatty acids, that is, as my mother was telling, that this can help to regulate the prostaglandin, thereby decrease the inflammatory reaction and cytokine physiology. Use of high fiber diet, use of vitamin D, calcium reduces the pro-inflammatory cytokines. Which should be avoided is use of trans meat, red meat, alcohol. This should be avoided, because consuming a lot of this fat, the red meat and all these things, leads to increased tumor necrosis factors, and it activates the inflammatory pathway, which leads to more aggressiveness of the disease, as well as it's going to cause more pain to the patient. And also you can advise that if she's a patient who takes a lot of coffee, you can tell she has to reduce her coffee because it also increases the sex hormone binding globulin. And again, we all know endometriosis is a hormone dependent disease. So this is invariably going to increase the progression of this disease. And this is a study which was published in 2013. So here they have mentioned that endometriosis is commonly seen in patients who consume fewer vegetables and omega-3 polyunsaturated fatty acids, and those who consume more red meat, coffee, and trans fats. But ultimately, they concluded, even though there is association between diet and endometriosis, since this finding did not replicate very consistently across the population, and hence need for more studies in this diet and endometriosis. So now coming to vitamins, how vitamins will help in endometriosis, because it reduces the oxidative stress and reactive oxygen species, which actually reduces the cellular proliferation and activation of this endometriosis. Apart from this, there is also altered lipid metabolism and epigenetic abnormalities. Hence, use of antioxidants in the diet, especially N-acetylcysteine, is a powerhouse of antioxidants. So, use of N-acetylcysteine and high antioxidant diet can help the patients with endometriosis. So, what about the physical activities? Is there any specific physical activities that they should do to reduce endometriosis pain? So, Pilates is one of the exercises that is recommended, and use of muscle relaxation exercises and commonly pelvic floor exercises will help to reduce the pain. And there is a study, PICO study, which actually mentioned 30 minutes of brisk walking and 1 hour of aerobic exercises twice weekly is recommended, because this will prevent reduction of bone mineral density in patients who have been on GnRH analogs. Even then, even if the patient is not on analogs, this exercises requires the patient to restore a normal tone, decrease muscle tension, and induce relaxation. Thereby, it is proved that it will help in the improvement of our symptoms. Next, coming to the herbal and complementary therapies. Herbal therapies like turmeric, ginger, lavender, peppermint, cloves, and so many, it's available in the market. But in traditional Chinese medication, the mixture of these things are used, and it is proved that it reduces primary menorrhagia and reduces the uterine contraction, thereby causes some relief in the dysmenorrhea or other symptoms of pain. The other complementary therapies: acupuncture, heat and cold compression, stretching, and osteopathic manipulative therapies, and your neuromuscular electrical stimulation and transcutaneous nerve stimulation can be used. So if you are suggesting your patient electrical stimulation, what is the frequency? That is, it has to be done 20 to 30 minutes twice or thrice a week, and it has to be continuous. It's not enough that she undergoes it for 1 week or 2 weeks. The minimum recommended duration is 8 to 10 weeks. And over a period of, on the consecutive sessions, she is going to have a pain relief. It's not going to happen in the first or second session. So this has to be explained, and she has to have a continuous treatment with this. And this has proved that it's reduced a significant reduction in pain, and thereby it has increased the quality of life. And also they noticed that use of these techniques has reduced the need for painkillers in patients with endometriosis. Now coming to the cognitive behavioral therapy. So it is, we all understand that this is a very chronic disease, and most of the patients with endometriosis will have underlying depression, because of which their quality of life is affected. And, so many of them suffer not only physically, but also mentally. So these patients who are diagnosed to have proper depression has to be on some medication. But as a start, there is no necessity that everybody should be going through medicine. It can be a CBD sessions which will help them, like type of counseling, which will help to improve the pain and also the depression scores. This will also help to normalize the cortisol levels, which help to reduce the perception of stress and also improve the sense of vitality and functionality in a daily life. Increased sense of well-being and improved quality of life is something which every patient with endometriosis is looking for. And with this minimal, these kind of interventions is definitely going to give some sort of improvement in their day-to-day life. Now coming to the mind and body techniques. These patients can undergo yoga and breathing. Even the PICO studies had proved that of yoga with breathing and psychological intervention at significant reduction in pain and the need for other painkillers. So, and they have to prioritize their sleep, and because it improves their overall health and can reduce the inflammation, because during sleep the cells undergo repair, and sleep is one of the very important thing we should ask the patient to prioritize. And of course, as ma'am mentioned, the support groups and counseling, the peer group, the emotional support, which most of us will not, with the patients who have endometriosis, by sharing their own journey, their own pain, the patients can have their own emotional well-being when they get connected with this other patients with endometriosis. So the holistic approach in endometriosis is an effective management in supporting traditional treatment. This is a systematic search and narrative review published in 2024, and they mention that physical activity, manual therapy, electrophysical agents, acupuncture, diet, cognitive behavioral therapy showed no negative effects. But of course, on the other hand, it reduced pain, improved the quality of life, and reduced the perception of the stress. So definitely, even though it is not a primary treatment, but definitely these treatments can be used as a adjuvant in patients with endometriosis. So now coming to hormonal medication, the commonly used hormonal medication is NSAIDs. And if the patient have very severe pain, we can use neuropathic painkillers like gabapentin, pregabalin, and even some antidepressants are being used in patients with endometriosis, especially chronic endometritis. And use of tumor necrosis alpha antagonist is gaining importance, and phytotherapeutic agents like resveratrol also can play a role in endometriosis. So we all know NSAIDs are the first line painkillers, and but the side effect when taking it for a long time, like even though we prescribe them for like days, but patients without our prescription, they might take it for a long time, and this can cause some side effects and other kidney issues. And NSAIDs, again, naproxen and COX-2 selective NSAIDs can be used instead of stronger NSAIDs. And other medications like paracetamol, neuropathic pain medications like gabapentin, pregabalin can be used in patients who are like not responding to the primary painkillers. You can use higher painkillers, and opioids are reserved for patients with very severe conditions. And antidepressants, it can also be suggested in patients where you have diagnosed a patient with depression, because in endometriosis patient, depression is very common, and more than 70% of patients with pelvic pain can have some underlying subtle depressive symptoms. Now coming to tumor necrosis alpha, it's an alpha antagonist. How it acts is it suppresses the inflammatory and vascular pathogenic pathways, thereby decreases angiogenesis and inflammatory mediators, thereby reduces the pain and improves the quality of life. So resveratrol is a phytoestrogen, and it is naturally seen in red wine, grapes, berries, and all this food materials. This molecule is said to reduce the proliferation, vascularization, and reduce the free radical oxygen formation and promotes apoptosis. It is dose dependent, and it also reduces or stops angiogenesis at higher dose, and also represents a promising therapy in future for treatment of endometriosis. Now the upcoming one is the kisspeptin and endometriosis. They are thinking in terms of, because kisspeptin altered signaling can lead to abnormal hormonal and environment observed in endometriosis. So by altering the kisspeptin and its receptors, they are looking at future of endometriosis. They are looking at altering the scan may help in endometriosis treatment, but it is still under research, and it needs further studies. Coming to surgical management is typically considered in patients where medical treatment fails. As my mother said, like if you are going to go for a surgical treatment, it has to be the best, and definitely it can be tried if your medical management fails, and the goal of the surgery should be to relieve the pain of the patient, restoration of the normal anatomy, and wherever necessary, preservation and enhancement of fertility, and complete excision and ablation of the endometriotic lesion should be your target. So as we all know, the common treatment options were conservative and definitive. Definitive, of course, is hysterectomy or oophorectomy, But conservative procedures like ablation, excision, resection, and cystectomy can be performed. But if you're going for conservative management, definitely follow-up is recommended. And again, laparoscopy will be the best mode of choice, then laparotomy. Now, what are the emerging new treatments? Immunotherapies. Stem cells is gaining more of attention, especially with endometriosis, nanoparticle-based therapies, and tissue engineering. So, immunotherapy, because we understand that endometriosis is a dysregulated state of macrophages and other immune cells, which actually, triggers the inflammatory pathway, and hence using immunotherapy to some extent, it can be of help in patients with endometriosis. But this is a very new, I don't think we are very commonly using it, but maybe the experts can say it is under the research, like the drugs are being tried and it is further research are needed in this therapy. Stem cell therapy, again, it is the same. Especially it is particularly using menstrual blood derived stem cells and mesenchymal stem cells, so promise to repair the endometrial tissue. But again, I'm little skeptical about it because the pathophysiology itself is the retrograde menstruation. So I don't have much things to say, because even in material, there was very limited material in regards to stem cell therapy in endometriosis. Nanoparticle-based therapies are loaded with glucose oxidase are being developed in targeted delivery to endometriotic lesions. This is something which can be targeted. And exosome-based therapies and tissue engineering, still we have a long way to go. And putting up an overview, the evidence-based is still lifestyle modification is number one, followed by diet, physical activities, electrophysical agents, acupuncture, CBD. These are some proved non-hormonal and adjuvant treatments which you can use along with your primary treatment of endometriosis, and analgesics and surgical treatment. But certain things are under research, and before we proceed with those kind of treatment, we need a very stronger studies to go ahead with. So conclusion, a holistic individualized approach that integrates non-medical strategies with medical and surgical treatments offers the most comprehensive management of endometriosis, and non-medical interventions can significantly improve the symptoms and quality of life, which is what we are looking in patients with our endometriosis. It should be again a personalized, implemented under guidance of healthcare professionals. Because of use of the social media and so many things, so many patients come to us, seeing all this stuff in the Instagram and all these things. So we have to emphasize it should be under the guidance of a healthcare professional, and multifaceted approach may lead to a better long-term outcomes. I thank everyone for giving me this opportunity. And if there is any questions, I'm ready to take it.
Dr. Archana, is there any
Yes.
role for gluten-free and lactose-free diet in endometriosis? Does it benefit the woman?
Yes, ma'am. Certain, as a Asian population, some especially patients with endometriosis, they have a lot of lactose intolerance.
Yeah.
So in these patients, even when you formulate the diet, the history for lactose intolerance has to be taken. And and if they have that, definitely avoiding a lactose substance will help to relieve the symptoms. Definitely, yes.
Yeah, as you said, there has been a lot of importance which have been given to this vitamin D3, food with a lot of antioxidants. Anti-inflammatory diet.
Lot of antioxidants are available in the market, and N-acetylcysteine, astaxanthin, and so many things are available in the market. But out of which, if you have to select one, because we come out with a lot of combinations of drug of antioxidants in our market. But the problem with all these combinations is they don't have the required correct amount of antioxidants which is needed. So what happens is, even though you're giving antioxidants with multiple combination, you are not substituting the patient with the required amount which is recommended. So what we usually suggest is to go for individual antioxidant, and in that case, if you have to select one or two, is N-acetylcysteine is the number one antioxidant to be chosen in patients with endometriosis.
Okay, and what is the dosage which is recommended, and where is it? Like, how is it available?
600. It is available as effervescence tablet also, ma'am. And even
Okay.
IV therapy of N-acetylcysteine is also available.
Okay.
That's what Hema, I said. N-acetyl
Ah.
cysteine with palmityl ethanolamide is available in the regular, as a nutraceutical. So that can be tried along with antioxidants and magnesium. Then one more thing is, now we have the newer microbial therapy. Microbials are said to be dysregulated in endometriosis, and that specific organism, microorganisms like the Prevotella, Actinomyces, and so many other bad bacteria overgrow that healthy one, and hence a combination of appropriate antibiotics. Probably they are all claiming that ciprofloxacin and then levofloxacin are supposed to be helpful in management of endometriosis, along with lactobacillus supplementation.
Okay, madam.
So that is also being spoken
Prebiotic
a
and
lot.
probiotic. Yeah, prebiotic and probiotic can be
Prebiotic and
substituted.
probiotics are coming up in a big way.
Okay. Like that is where the role for our padaya sadam
Yes.
and all the fermented food.
Fermented food is being welcomed.
Yes,
It's supposed to be contain a lot of antioxidants.
Yeah.
So any other person who wants to have any discussion? Sir, PDM sir, and others, otherwise Pradeep sir.
Yes. Hello.
Yes, sir, you are audible.
I can hear you, sir.
Okay, thank you. Now, I think we must understand that the disease of endometriosis is a systemic disease. So whatever we do, we still do not know the right answer. We see so many things have been proposed, is only proposed, nothing is confirmed. Whether using magnesium or anything else, we are still collecting the pebbles in the vast sea of ignorance of this issue. So whatever we say, maybe there is some research, but that research does not guarantee the improvement of the patients. The quality of life improvement can be affected by your exercises and diet control. But who is going to listen to you? Patient comes to your clinic, they want to immediate remedy. They want to be cured of the disease. Can you tell them that I am prescribing the medicines, it's going to cure you? The answer is no. So we are in a mess. We are trying to find out something to escape us from the great problem of endometriosis, which is affecting the quality of life of vast majority of women who are suffering from the disease. Whether medical therapy or with surgery, everything has its own benefit. Also, they have their demerits also. So we have to come to a conclusion that medical therapy or surgical therapy is not the cure for this disease. We can only improve the quality of life to some extent, not to the full cure of the disease. That's what I would like to comment. Thank you.
Well, both the speakers have spoken very nicely, but one point is that this deliberation should be time framed. It should be a little bit shorter so that this discussion can be continued, number one. And another point I would like to highlight that yes, with time we are getting more and more confused. What is to be used regularly and what are coming up, and those which are coming up, out of them, what would be appropriate in future. So with time, more and more confusions and other things are being noted by all of us, and I think only this is the subject of which we know very little even now at the moment. Anyway, let us pass on to the next speaker.
Thank you, Dr. Archana. And now let us move on to the next topic, which is MRI in endometriosis. Yes, it is an interesting topic. We used to say that it was said that laparoscopy is the gold standard for diagnosing endometriosis, which is no more a dictum now. So the thing is, the gold standard for diagnosing endometriosis is ultrasound. You diagnose endometriosis with ultrasound, and to confirm the diagnosis of endometriosis, also to map the map the lesions, extent of the lesions, and involvement of the nerves, and also the organ involvement. We rely on MRI in a major way. So we invite Dr. Babaharan Rajalingam to throw lights on MRI in endometriosis. Over to you, sir.
Audible, madam. Am I audible? Yeah.
Yeah, you're
Yeah.
audible. Thank you.
Shall I share
Yes,
my
sir.
screen?
Share your presentation.
Thanks.
He's a very senior radiologist from Tiruchirappalli, and then he's an expert in MRI in adenomyosis and endometriosis. Most of my patients I send only to him. What impression he gives will be the exact replication in when we do the surgery. Welcome, Dr. Pavaharan.
Thank you, madam. Thank you for your kind words. So, dwelling into the topic for the next 15 to 20 minutes, we'll just go ahead with how does MRI help in the diagnosis? Do we have limitations? Yes, we have limitations with MR also in certain cases. But in adenomyosis and endometriosis, how is MR going to help? There are only very key features that we need to see in these conditions whenever these kinds of patients are referred to us. So many of the times, patient comes for a fibroid mapping, but the patient also has an additional adenomyosis in those cases. So that's how incidentally sometimes adenomyosis being picked up in many of the cases. So adenomyosis has a very high diagnostic accuracy of about 85 to 90%. So the hallmark finding in MR for adenomyosis is junctional zone. So any junctional zone which is more than 12 millimeter is considered to be the diagnostic criteria for adenomyosis. But the problem is there is a limitations that these definable junctional zones are not seen in premenopausal women, that is exactly between, let's say, 45 to 48 years of age. Sometimes these junctional zones are not very, very clear. These are the problem that we have with MR. So you could see here, let me pick up the pen. Are you able to see the marking here? Yeah?
Yes.
Some pen marking, yes. So this is the endometrium. This is the myometrium, which is heterogeneous. It's quite normal. This is how actually any reproductive uterus looks like. This is not anything abnormal. And the central bright line or white line you see, this is the endometrium. And this is a junctional zone. So this junctional zone is the zone where actually usually it is between 5 to 8 millimeter. Whereas here you could see the same junctional zone varies from 3 millimeter in this case to about 7.5 millimeter in this particular patient. This happens due to hormonal influence too. That's why a wide range of about 2 to 8 millimeter or 5 to 8 millimeter is generally kept for endometriosis. Now, this is a clear-cut mid-cycle phase endometrium, which is hypoechoic, which is absolutely black in color, you could see here. And this does not have any heterogeneity, it does not have some so bubbly appearance. So this is a normal endometrium, which can be between 5 to 8 millimeter, which is called as a junctional zone. Usually the MR has microcysts. That's what we generally have in these cases. Let me show you a few cases here. You could see that these are thickened. You could see here definitely the junctional zone. You don't have an exact delineation. I told you this is the endometrial lining, whereas this is the myometrium and this is the junctional zone. Definitely here the junctional zone is thickened and there are multiple small echogenic. You could see bright spots here and there in the endometrium as well as in the junctional zone. This is the classical finding that you get in cases of adenomyosis. And similarly, you could see here also a thickened junctional zone with small microcysts that you see in the subendometrial region. That is what we see here. So these microcysts can be clear water. It can be hemorrhagic sometimes. This is because sometimes your MRI report may say hemorrhagic cyst, sometimes may say it's clear cyst. This is primarily because it depends upon at which phase of the cycle the MR is done. That is very important. So Water signal is actually seen at the end of the menstrual period. You could see that's clear water or fluid, whereas sometimes it is hemorrhagic in rest of the phases. Whenever you take it in about third day or fourth day of cycle, sometimes it will be hemorrhagic because the patient has had her periods and immediately are taking in about another 3-4 days. These cysts tends to be hemorrhagic. So here again, you could see there are microcysts which can be pathognomonic. Sometimes a larger microcyst can be seen. Larger cysts can be also seen in the myometrium. These myometrial cysts, you need to differentiate it from accessory cavitating uterine malformations, which is classically occurs on the right side, close to the level of round ligament. The patient will have pain from the day of menstruation. Usually, that is where actually you should actually pick up that it could be a cystic malformation of the uterus or accessory cavitating uterine malformation, which is a close differential diagnosis in this case. Again, these images where you see the bladder as white color or rectum as white color or bladder fluid as white color. This is called the T2 sequence. When you see the image, this is the most common image that is being used. That's a T2 image. This is again a T2 image. Whereas here you could see the bladder is black here. So this is a T1 image. So T1 image, T2 image, this is the primary tool that we generally use for picking up uterine adenomyosis. So the junctional zone thickness, again, is very important. More than 12 millimeter is diagnostic. Obviously, here you could see this is a thickened junctional zone throughout, and you could see multiple bright spots. You could see when you actually take into consideration, there are multiple bright spots everywhere through the myometrium. So these are classical findings of adenomyosis. This patient also had adenomyosis. A bulky uterus was reported on ultrasound. The patient came to us because patient had severe abdominal pain. So in order to assess the uterine adenomyosis, the patient was referred. And you could see definitely the junctional zone is thickened. Definitely junctional zone is thickened and is heterogeneous. It is not a clear black color or white color. It has multiple small spots and also has associated fibroid in this case. So this is very important. So this indirect signs of like thickening of the junctional zone, multiple cysts, these are secondary to reaction of the myometrium provoked by endometrial invasion. So this indicates that there is an endometrium tissue which has invaded into the myometrium and has caused these changes. So thickening of the junctional zone and microcysts, and these microcysts can be clear, can be hemorrhagic. That is because of the time period in which you ask for an MR in these cases. So both are same, right? Sometimes you could see a focal mass. This is again a thickening junctional zone, but again you could see an adenomyoma sitting in the anterior wall of the uterus. So again, there's a retroverted uterus. You could see the endometrial lining. You could see the bladder is white. So this is a T2 image, and this T2 image has a irregular thickening. Usually fibroid is well defined and it has the classical T2 hypointense appearance in case of menstruating female. Again, this is another case where you could see that the junctional zone, this is the endometrium. You could see this is an endometrium. So in this case, the endometrium myometrial junction is completely lost in this area. And definitely there is invasion of the endometrial tissue into the myometrium. You could see multiple small cysts. The junctional zone is thickened. And you could see the anterior wall is more thick than the posterior wall. So this is a definite case of adenomyosis. Patient also has a fibroid, which is a subserosal fibroid sitting on this in this case, as well as another fibroid sitting in the anterior wall here. So again, this is bladder, which is white. So this is a T2 sequence. So, but there are limitations of MR where the junctional zone sometimes varies within the menstrual cycle. So that is why a broad classification, only when the junctional zone is more than 12 in any part of the menstrual cycle should be considered diagnostic of adenomyosis, number one. Number two, the microcyst has to be picked up in these cases. There can be focal adenomyomas and there can be larger cysts. If the cyst is larger, it has to be differentiated from accessory cavitating uterine malformations. In endometriosis, usually whenever the endometrial tissue is seen outside the uterine endometrial cavity, that is, it happens on the surface of the ovary, you know that, and you have the retrocervical region where it is infiltrated. It can go into the bladder. When it goes to the retrocervical region, here is where actually the uterosacral ligament is attached. The sacrum is coming here approximately. So the uterosacral ligament is attached this way, and there can be infiltration in this particular level. It can also infiltrate the bowel and can cause bowel endometriosis. It can also be in the anterior abdominal wall and can cause infiltration. Post-surgical, there can be abdominal wall endometriosis or scar endometriosis in these kind of cases. So this is an estrogen-dependent disease, and you all know about the complications. What are going to be symptoms? I need not elaborate to the esteemed gynecologists here. On MR, we have multiple protocols. Now, do we have to give contrast in all the cases? No, I don't give contrast in all the cases. Only when I have suspicion that there is a suspected hemorrhagic cyst with a malignancy sitting over that. If I have a suspicion in my mind when I see the plain CT, only then I give a contrast. Otherwise, in MR, the contrast is not given. One condition is that whenever there is a suspicion of malignancy, I give contrast, number one. Number two, whenever we have an infiltrating lesion, for example, when it goes and infiltrates into the bowel, let's say it goes infiltrates in the rectum, then I give contrast. The contrast is given in two styles. Whenever you have rectal infiltration, one is we give a jelly through the rectum so that it distends the rectum, and we give IV contrast, gadolinium contrast, to see how far the infiltration has occurred, whether the infiltration is serosal or it has gone to the muscularis area or it has gone deeply into the mucosa and submucosa region. Only then we need a contrast. Otherwise, in MR protocol of endometriosis, generally contrast are not used, right? So usually these endometriotic cysts are low to intermediate signal intensity. Low to intermediate, that it is not too bright, not it is too low. You saw the bladder, that's why I was putting T2 and T1 in all those cases. The bladder is bright. So the endometriomas or the endometriotic cysts in the ovaries or the adnexa or the paraovarian region will not be as bright as bladder in T2 images. In about 95% of the cases, it will not be as bright as it, right? So whenever the hemorrhage is or the endometriotic content is very dense, that is, if you do the MR immediately, let's say 4th day or 5th day of the cycle, generally the endometriotic cyst has more of endometriotic hemorrhagic contents. So it will be bright on T1. That is, in T1, we told you that the bladder will be black, but in endometriomas, the endometriomas will be very bright on T1 weighted images. So this is a superficial endometriosis. Again, you could see here, it is not as bright as bladder, but there are multiple cysts here. There are multiple cysts here. When you do a T1 image, this is a clear cyst. Now you can differentiate. There are two cysts, one here and one cluster of cysts here in the ovary. Now this cyst is bright on T2 and dark on T1. So this is a T1 image. This is a T2 image. So this is like bladder. This is like bladder. So this is a clear cyst. Whereas you could see small deposits on the surface of the ovary here, which is low to intermediate or slightly brighter on T2 and brighter on T1. This is an endometriotic cyst. This image I've just posted you to show the difference, how clear follicle and an endometriotic cyst we see in the same ovary. This is a case of deep pelvic endometriosis, where it is due to subperitoneal infiltration of the endometriotic deposits, otherwise called as Cullen syndrome. Again, you could see it here. It is there in the cul-de-sac. It is there, and definitely the infiltration is very, very clear here. It is, again, there is a clear infiltration. Again, you could see it is sitting. This is the bowel. This is the rectum. It is sitting on the wall of the rectum, but it is not infiltrating the rectum in this particular case. So it is a deep pelvic endometriosis abutting or adherent to the rectum, but it is not infiltrated into the wall of the rectum. So this is what, as radiologists, we generally look into. When we report a case of endometriosis, it is important to say the mapping of endometriosis. Where are the endometriosis there? And what are the organs that is involved? Or are these spaces free? That is what we try to demonstrate. Coming on to the neuro or the nerve extension, only when it gets closer to the sacral plexus, we can do it. Otherwise, pelvic nerve infiltration, for example, whenever there's a small nerves in the parametrium that has been infiltrated, which you generally see by laparoscopy or laparotomy, in 70 to 80% of the cases, cannot be so clearly picked up on MR in these cases. Only when it is having a sacrotuberous ligament, sacrouterine ligament infiltration, or when it is close to the sacral plexus, then you will be able to pick up the nerve involvement. This is another case where actually there is infiltration of the endometriosis in the cul-de-sac. Again, you could see the wall of the rectum is very clearly seen. It's just indenting on the bladder, but it is not infiltrating the bladder. So these are the informations on MR that we will be able to give. Right. Next comes the torus utrinus, where the sacrouterine ligaments attached, and the posterior fornix is a common localization for endometriosis. Again, here, if you could draw a line, see here, there is a definite infiltration here. You could see here, that is the infiltration. Here, you could see that it is going there. That is the ligament is thickening there, and this irregular nodularity on the surface. So this is where there is a torus utrinus, and the sacrotuberous ligament, that is the sacrouterine ligament, is actually infiltrated by the endometriosis. So this is done with clear, thin sections of MR that we generally put. Again, you could see there are fluid and hemorrhage level. Can you see that? This is a single cyst, but it has levels of fluid. So this is again done immediately, let's say on about third or fourth day of the cycle. So we were able to pick up those kind of differentiations in an endometriotic cyst. Again, this is an example of deep pelvic endometriosis. You could see here it is definitely infiltrating. You could see that it's definitely irregular, adherent, and it is adherent to the large bowel also. You could see here it is going here. It is just going. Yeah, it is infiltrating. Again, you could see a thick band here going and getting attached to the bowel. So though it is not infiltrating the bowel, these are attached or adherent to the bowel loops, which you might find it difficult when you go inside. It will be like a plastered one. Then a caution has been already given by the radiologist to the gynecologist saying that there is an fibrotic strand which runs through and gets adherent to the rectum. So we need to dissect that particular plane. So similarly here, you could see here, that is the posterior sac, that is where it is. And it is again, you could see here, it is going and getting small attachment. You could see here that is a fibrotic band going here. That's a fibrotic band going here. So these are surgically proven adhesions also, which I am showing it to you. Bowel involvement, again, as I told you, it's very, very, very important. You could see here that from the uterine cavity, there is a large mass sitting here, posterior to the uterus, ill-defined mass, which is sitting there. Patient came with, sometimes, patient comes with severe constipation or sometimes hematoschisia whenever the patient tries to pass urine. And you could see there is a para-ovarian endometrioma also that is there. And this is definitely infiltrated the bowel. You could see the bowel wall is thick here and it is infiltrating up to the mucosal level. So this patient actually came with history of hematoschisia, and during menstruation, we actually did this, and this patient went in for resection of that particular bowel loop and then reanastomosed. Patient had severe pain during menstruation, also had hematoschisia during this particular, during her periods actually. Rectal narrowing can also be sometimes present in this case. So here you could see that we have distended the rectum here, but you could see this is the uterus. This is the uterus. And you could see an ill-defined, very adherent mass sitting in the posterior aspect, and it goes and infiltrates into the bowel loop, and it has infiltrated throughout. That is, circumferentially it has infiltrated. You could see here, it has infiltrated the posterior wall also, and also the anterior wall. That has led to narrowing of the rectal lumen in this particular case. This patient presented as history of constipation, though there was no hematoschisia in this case. Bladder involvement, again, you could see string of pearl appearance. So this is again, bladder is black. So this is T1. This bladder is white. This is T2. So if you remember these two, that will be the best thing. So bladder is white on T2, bladder is black on T1. And you could see this endometriotic cyst lining the bladder. It has gone into the submucosal layer. You can classically see the patient has hematuria. This was the history of the patient. Patient had hematuria, and you could see here, there is infiltration of the mucosal lining of the bladder, and the endometrioma has infiltrated already. This is another case. You could see here, it has infiltrated the serosa and also gone into the submucosal layer of the bladder. So these all needs to be evaluated before surgical involvement. Both ovaries has multiple endometriotic cysts. You could see here, multiple times the ovary would have undergone this particular event in every cycle of the menstruating woman. And you could see there are extensive adhesion and both ovaries are adherent to each other. You could see both ovaries are in midline, adherent to each other. And sometimes, my professor used to say, when you are able to see both the ovaries in the cul-de-sac or close to the uterus by a transvaginal ultrasound, there should be some kind of an adhesion in this particular case. So here you could see here these are kissing ovaries. They are called kissing ovaries, which is due to again adhesions. Ureteric involvement, again, this patient actually presented with acute left-sided colic. The patient presented with acute left-sided colic, thought of renal ureteric calculi. So this patient underwent an ultrasound, and ultrasound showed nothing except for a mild hydrohydronephrosis. He could not pick up a calculus. We did a CT, and on CT also we actually found out there was something which was around the left ureter that was constricting the ureter. So we couldn't actually see. CT again sometimes will give you narrowing, but it will not give you details, soft tissue details as much as what an MR gives to you. So this MR was immediately we just put the patient on MR for a screening in this case, and we picked up there was extensive adhesions from the uterus. It is going and encasing the ureter. This patient has not underwent any previous surgery for calculus or no evidence, no history of any LSCS in the previous pregnancies. They were all normal deliveries. So this was an endometriotic nodule, which is a periuterine infiltration encasing the ureter. Sometimes these kind of patient presents even with hematuria in these cases. So again, cyst, as I told you, is very simple. So bladder is white. So this is T2, bladder is black. This is T1. So the cyst is hypo on T2, hyper on T1. So this is the opposite. You could see this is bright, this is black, and bladder is black, and this is white. So this is nothing but endometriomas. As simple as that you can diagnose. Similar, bladder is black, cyst is white. So this is an endometriomas. Again, cyst is white, and the other cyst is not or dull. That is again endometriomas, ovarian endometriomas. Simple. So whenever there is bright bladder, white bladder on T2 and black cyst, and black bladder and white cyst, it is endometriomas when it is all in the reverse. This is a case where there is a ruptured endometrioma. Recently, we had this case. The patient presented with lower abdominal severe pain, and the patient was referred as ascites. The patient was referred for ascites, and they couldn't find out any mass except for cyst in the left ovary. So they wanted to know that if there is any malignancy happening in this case. But actually, again, you could see here, this is T2, bladder is white, this is opposite. Bladder is white, this is opposite. So here bladder is black, cyst is white. Bladder is black, cyst is white. So this is an opposite which you have in simple terms. So this is here you could see there is a ascites going on. There is a hemoperitoneum in this case also, and this turned out to be a ruptured endometrioma. So again, the differentiation is simple. You have to differentiate whether it is a follicle or it is a endometriomas in the ovaries. So as I told you, the reverse sign, the T1 and T2 reversal with bladder, comparison with bladder will help you diagnose in this case. Abdominal wall endometriomas, there are so many cases, but I just want to tell you, whenever we have an abdominal wall endometrioma or scar endometriosis, the role of us to say where exactly the plane is, whether it is in the subcutaneous plane or whether it is infiltrated the muscular layer, how is the rectus sheath happening, whether it has gone beyond and infiltrated the peritoneum, and how much length actually it is being involved. For example, when there's large defect involving the muscular layer, probably a plasty or hernioplasty has to be planned in this case. So in those cases, where is the lesion and how far is the involvement of base and how deep is the lesion is what as radiologists we need to consider. So MRI is very highly sensitive in about 90% of the cases where there is a non-invasive imaging technique in deep infiltrating endometriosis, adhesions, and endometriomas. And it's also helpful, very good in pre-surgical mapping. As I told you, all the areas has to be assessed before giving a final conclusion. Extra pelvic evaluation. Again, is there involvement of close to the sacral plexus, sciatic nerve involvement, and the abdominal wall involvement, and also the peritoneal involvement. Again, limitation is that it is while highly effective, small peritoneal lesions sometimes may be missed in these cases. So this is what MR in endometriosis is all about. So I'm open to questions if there is any. Thank you for the opportunity.
Thank you, Dr. Babaharan. Do you mean to say even for a pre-surgical mapping, gel contrast imaging is not necessary?
Whenever it is involving the posterior fornix, or it's close to the sacrotuberous ligament, then we generally give rectal contrast in those patients actually. See, many of the times before doing an invasive procedure, whether it is contrast giving to rectal or giving an IV contrast, I would generally look into saying whether it is really necessary in this case. I'm able to diagnose, or is there any particular lesion which I have to see in detail in this case. See, again, there is a lot of claustrophobia involved with MR. Patient has to be there for 15 to 20 minutes in MR. Putting the gel in MR, again, it's very, very cumbersome for a female patient actually. So whether to actually give it or not is very essential. So I generally pick my patients to give whenever it is necessary. So whenever it is involving the posterior fornix, yes, we give rectal gel, and then we distend it, and then we look for analysis actually. Yes.
What is the role of
when there is only, let's say, endometrioma, I don't have anything in the there is no deep pelvic endometriosis at all. I don't think that we need not even put the patient under gel.
What is the role of IV contrast?
Yeah, IV contrast, I told you two indications. One is whenever we have a suspicion of malignancy in that case, number one. Number two, whenever there is a rectal involvement, for example, rectal or bladder involvement directly, to understand that whether it is infiltrating only the serosa, or it's going deeper or up to the muscular plane, or up to the mucosa, or breaching the mucosa, then we need a contrast in those cases. Only two indications for contrast. Not all cases of endometriomas require contrast in this case.
In an intrinsic involvement.
Sorry, your voice is breaking, man.
Ureteric endometriosis.
Ureteric endometriosis.
Okay now, sir? Ureteric endometriosis.
Okay.
A plain MRI is sufficient for to rule out ureteric stenosis jeopardizing the kidney.
Yeah. See, one is, madam. See, when you give contrast, see, on the plain MR for ureteric endometriosis, we generally see the uterus narrowed and obstructed. And there is hydrohydronephrosis, number one. Regarding the function of the kidney, MR contrast and then waiting for it to come and excrete is sometimes very cumbersome. So in those cases, a CT contrast would be helpful. CT contrast. Suppose if you want to know whether the kidney is functioning or not. That's what your question is, correct? So in those, whenever there is a question of whether there is functioning of the kidney is affected or delay in the excretion, then probably we give a IV contrast with CT to understand that the kidney is excreting properly in these cases. So in that way, we can do two things. Suppose when there is a delayed excretion of the kidney, generally these patients whenever the stenosis, the endometriosis is a fibrotic event that's happening around the uterus. So there is a adhesion level. So sometimes, putting even the wire across by ureteroscopy sometimes will be difficult. So in those cases, percutaneous nephrostomy or an antegrade stenting has to be attempted. So in all those cases, then we need to evaluate through a CT to understand whether the kidney is actually functioning in those cases. So MR is not the primary tool to assess the functioning of the kidney because we give very, very minimal amount of contrast. So this contrast, what happens in MR, it gets excreted by the opposite kidney, and the left side kidney is supposed to later.
To diagnose obstruction, sir, whether the kidney is functioning or not.
Yeah, that is what I see. We go in for a CT. Whenever there is an obstruction, we want to say whether the kidney is functioning or not. There are, I think CT contrast will be the better actually role to assess. Hey, that's what I'm saying. If you give an IV gadolinium contrast, what happens actually, the gadolinium given is about 5 cc or 7 cc. That's the maximum contrast that we give. So this is being taken up by the non-obstructed kidney and will drain, and here will be very minimal gadolinium that's excreting. So actually the kidney will be functioning, but you won't see the adequate density of the gadolinium to be evaluated. So in those cases, CT will be very helpful in those cases, when if the urea creatinine is normal.
Thank you so much.
Thank you.
Bhavagaran, it's a pleasure to listen to you. Thank you so much. Thank you so much for
Thank you.
distributing knowledge to our members. Thank you.
Thank you. Thank you.
So next,
Thank you once again, sir. The next topic would be newer drugs in medical management of endometriosis. Dr. Suranjan Chakrabarti, over to you, sir.
Just give the introduction about Dr. Suranjan. Pallavi, you throw his CV. Yeah, Dr. Suranjan is the Joint Secretary of ESI and he is the Joint Secretary for the International Congress on Endometriosis that was held last year, an organizing committee member of AICOG and managing committee member of BOX, and he is a regional faculty for certified course on GDM and conducted by PHIF, FI and DMEDA, and chairperson of Medical Disorder Committee of Bengal Society. And his special interest is high-risk pregnancy, endometriosis, vaginal surgery, minimal invasive surgery, and infertility. He has a patent on parietal drain device granted IPO on, recently it was given to him for 20 years. And he has attended many national and international conferences as faculty, contributed many chapters, and I think he is one of the important pillars behind the Endometriosis Society India. Welcome, Dr. Suranjan.
Thank you, Dr. Ramani. Am I audible?
Yes, nice.
Yes, sir.
Yes. Thank you very much for the organization. And I'm indebted to the organization and trying to fulfill that the task was imparted to me. I have nothing to say new. Already it has been discussed in details. All my previous speakers have discussed. So let me see how far I can satisfy you. I'm just sharing my pics. It's not going. Something problem. Oh my God. Yeah.
Any problem, sir?
It's not opening. Say hello, Zoom. D'accord. I'm trying. The hello Zoom is system. Just a minute. System setting. Sharing the channel.
Got it.
Is it okay?
Yeah, yeah.
Yes, sir. We can
Yes.
see your slides, sir.
Yeah, Suranjan, go ahead. Fine.
So I've been asked to go for. So for the today's understanding, the recent treatment landscape has shifted from the suppressive hormone therapy towards the oral GnRH antagonist and compare elagolix, relagolix combination therapy, and linagolix across mechanism, dose concept, efficacy, and safety. Am I audible?
Yeah, yeah, fine.
Okay.
Go
Yes,
ahead,
sir.
Suranjan.
Okay.
Yes, sir. We can hear you, sir.
Okay. So I'm trying to cover up this type. Though everything is overlapping, my previous speakers have detailed explained everything. Please excuse for that. The place of aromatase inhibitors, SPRMs, and emerging non-hormonal targets in the current evidence hierarchy. Use of practical framework for patient selection, monitoring, advanced therapy, and indication of surgery. Why this is happening? There's the disease biology, to oral GnRH antagonist era, drug trial evidence. I'm with it. Now, why this topic matters now? Envisage as of now, the evidence base, everybody knows, is more than 10 to 20% almost. Gradually is emerging. The more we are coming in contact, more and more numbers are being evidence were encountered and probably less reported. And moreover, it is coming from the adolescents too. And the major changes in the last decade is not only simply another hormonal option, it is the arrival of oral, rapidly reversible, dose-flexible GnRH antagonism, allowing partial suppression or deep suppression with a more deliberate use of advanced therapy. So this is the chronological order. 2018, Ilagolis US approval got, and 2022, Ilagolis combined therapy and endometriosis level, and 2022, ESRA guidelines positions oral antagonists, and 2025, linagolix and European Union and NICE, they have approved for use. This is the disease biology. Each and everybody is known for this. It's a estrogen-dependent inflammatory disease, ectopic endometrial-like tissue, fibrosis, pain sensitization, distance exhibit progesterone. In this context, I have to remind me that ectopic endometriosis is recently I have encountered one patient of my patient. They have got the laryngeal ectopic endometriosis. It was proved by the put on our gynecologist. She was a case of endometriosis, and she developed hoarseness of voice. And after us on laryngoscope, it's got the endometrial lesions, and it was cleared off with supplementation of gynecologist. However, later on, I have to do the hysterectomy for that. Well, okay. Apart from it, let's progress. Lesions exhibit progesterone resistance to increased local aromatase activity and altered immune surveillance. Pain can become dissociated from lesion burden because peripheral inflammation feeds central sensitization. Therefore, newer therapy aims not only to suppress evolution, but to lower estradiol into therapeutic window, and that reduces pain while limiting hypoestrogen harm. So what it comes to it, estrogen dependence, driven lesion survival, progesterone resistance, limit progesterone response in some patients, and inflammation, angiogenesis, such as implantation and pain, and neurogenesis and sensitization explains persistent pelvic pain. So why the standard suppression is often insufficient? Pelvic pain is multi-layered. Inflammation, hormonal, neuropathic, and central. Clinical approach is a drug can produce a statistically significant lesion or bleeding-related benefit, yet still underperform in a patient whose pain phenotype is dominated by central sensitization, deep dyspareunia, bladder, or bowel overlap, or additions of fibrosis. So newer endocrine drugs work best when you define the main pain driver before prescribing. Dysmenorrhea usually tracks best with ovarian suppression. Non-menstrual pain often needs multimodal management. Deep disease with fibrosis may still require surgery. These are the limitations of conventional medical therapy. In a nutshell, this slide contours. So start with the strategy NSAID, we can start of the early adolescence. Accessible symptomatic, do not fortify estrogenic drive or lesion biology, evidence quality is limited for chronic disease control. And COCs, that is also cycle control, inexpensive, breakthrough bleeding, passive pain, all that is already discussed. And position LNG IV is also useful first-line therapies. And unscheduled bleeding and mood acting is a problem. And GnRH agonist, there is a potent suppression by flare of effect, injectable, menopausal symptoms, constant bone loss, and advector dependence. Surgery, diagnosis, and lesions reduction. Recurrence is common, postoperative medical suppression is usually still needed. The oral antagonist concept aim to combine potency with faster onset, no flare, oral dosing, and dose flexibility. Then now the oral GnRH antagonist comes, rapid onset, oral administration, and the controlled hypostasis window. How it acts, everybody knows. It's a competitive receptor antagonist. It's acts on the hypothalamus, anterior pituitary. As a pulsate in GnRH is blocked in the pituitary level, is stopped. As illicit FSH output is diminished, and diminished at the lower level, target organ, ovary, no production of estradiol ovulation or suppression. So clinical consequences, lower illicit FSH within the hours to days, reduce estradiol into a therapeutic window, suppress dysmenorrhea more predictably than flare-prone agonists. So it's an oral GnRH antagonist, competitive receptor blockade, no flare, rapid reversibility, lesion, and pain pathways. These are mechanisms for how it acts on pharmacology. Is a receptor antagonist used to suppress gonadotropin-driven ovarian steroidogenesis in endometriosis-associated pain. Competitively blocks pituitary GnRH receptors, rapidly lowers LHS FSH secretion, reduces ovarian estradiol progesterone production, creates a dose-dependent hypoestrogen state, improves dysmenorrhea, and non-menstrual pelvic pain. These are the criteria. It blocks the receptor activation, lesion stimulation. Unlike GnRH agonist, elagolix suppresses the axis directly without an initial flare. This is the catch. Elagolix acts on pituitary receptor. So how it works is demonstrated and compared with the GnRH agonist with the initial flare which has been absent here. So what is the teaching implication? Is useful when rapid suppression is desired. Then agonist is given. So for the PGTs, the 5 points that you should remember is a class of the drug is the oral GnRH receptor antagonist. Primary side is the anti-pituitary. Endocrine effect, decreased LH and FSH, estradiol and progesterone. Therapeutic result, reduced endometriosis-related pain. Pharmacodynamic theme is dose-dependent ovarian suppression. So it is a receptor blockade upstream and creates endocrine suppression downstream. This is in a nutshell, compared the GnRH agonist versus antagonist. Everybody knows this. Was the positives and adverse one. I'm not going to details it. Why advec therapy matters. Therapeutic window of concept is that estradiol to a high level, continued pain. Advec therapy attempts to preserve efficacy while limiting vascular symptoms and bone mineral density loss. It becomes increasingly important when treatment aims for stronger estradiol suppression or longer duration. Relagolix is marketed as fixed-dose combination therapy. Linagolix has both partial suppression and advec strategies. Elagolix advec is emerging, but not the original level contrast. Do not think the advec is a treatment failure. Think of it as precision endocrine support. FDA approved the Elagolix in 2018. I was already said it. So dose is starting from the 150 milligram once daily, lower suppression, longer duration can be allowed, and 200 milligram twice daily, deeper suppression, stronger efficacy, shorter allowed duration. Elagolix established dose-dependent suppression is idea. Symptom control is very good with deeper suppression, but vasomotor symptoms and bone loss rise too. Onset rapid pain improvement without agonist flare, strength particularly good effect on dysmenorrhea. Trade-off hot flashes and BMD loss are dose-related. Practically a useful benchmark for understanding the class. This is already same thing, almost. Efficacy, the study protocol, how much dysmenorrhea overcome, study clinical. So this is the 24 months, 150 milligram and 200 gram 6 months. What's the result? Hot flashes, how it is diminished, but with the placebo, and it causes the side effects of the insomnia too. So the best used when dysmenorrhea is a dominant and patient accepts a finite duration side effect calibrated course. It should be taken up. With Advac therapy, there is emerging refinement. It shows the field of moving from a binary suppress or do not suppress mindset towards longer course endocrine engineering. The question is no longer only whether antagonists work. It is how to make them durable enough for chronic disease. Mentioned as a future-facing strategy, not as the original landmark level construct, connected to a broader success of relagolix combination therapy and linagolix Advac approaches. FDA approved relagolix in 2022 with estradiol 1 mg, northromycin 0.5. Is the agonist efficacy pre-packed Advac support. Limit use up to 24 months because bone loss may not be fully reversible. Why it is conceptually important, relagolix combination therapy moved Advac from an optional medication strategy to center of the product design. This made long course of antagonism clinically realistic. It's a dose, 1 tablet once daily, patient appeal, oral, no injection, no flare, no separate Advac prescription. Main cavities, estrogen containing, not suitable for every disease profile. Evidence-based, strong phase 3 and extension data. These are the evidence-based. I'm not going to details of it. I'm saving it. Is the practical guidelines. So linagolix also is European Union and UK NICE guidelines is accepted there. For linagolix extends the class by offering 2 distinct therapeutic concepts in the PREPARE program. Is 75 milligram, 70 milligram without Advac, partial suppression strategy, and 200 milligram with Advac, deep absorption strategy. It makes the precision suppression concept obsolete. As of 2025, NICE and European material support linagolix with hormone Advac therapy as an option for endometriosis associated pain, especially in people who already had prior medical and surgical treatment. 2-dose concept, best site for discussing partial versus deep suppression, Advac integration, parallel linagolix combined therapy, but keeps more regimen flexibility. Geographic habit, availability, and regulatory status differ across regions. This matters in. I'm just skipping these slides. Now, how is a little bit of the receptor, how it acts is an antagonist, agonist acts as the receptor. This is for the theoretical aspects only, not for the clinicians. How it acts, the receptor type of receptor is the GQ couple, and how it acts. When it activated, it triggers the phospholipase C pathway, leading to production of inositol phosphate, IP3, and acylglycerol, which then increases intercellular calcium levels, promoting the release of FSHLH. And it activates this active research GnRH agonist for endometriosis. For example, Kissel Pharmaceuticals is running a phase 3 trial on linagolix, a GnRH antagonist, to compare its effectiveness against GnRH agonist in reducing endometriosis-related pain. Additionally, 2024 systemic review suggests that while GnRH antagonists can reduce pain, high doses are not recommended for long-term use due to potential side effects. Now, beyond GnRH antagonists, what remains useful, what disappointed, and where non-hormonal discovery is going. So, rationalized aromatic inhibitors. Here comes the letrozole therapy. Already, as we discussed it, aromatase inhibitors remains valuable as second or later line adjunct in difficult disease, but they have not replaced oral antagonists for mainstream academic discussion because convenience and long course tolerability are poorer. Refractory best fit in refractory pain after other hormone options. Not deal if patient wants simple monotherapy. Deep disease under specialist care. Bone risk profile is already unfavorable. Combination strategy discussions, monitor access is poor. In this context, I pay homage to my learned teacher, Professor Budhya Chakraborty, who is the founder president of Endometriosis Society of India. His thought was detect them early, catch them early, and treat them early. On this letrozole aromatase therapy, this letrozole, when he was alive, in his institute, low dose letrozole, this study was conducted, an effective option for women with symptomatic adenomyosis awaiting IVF. A pilot randomized control trial was gone. It was published in LBSR. You can go through it. Yes, in his lifetime, he has shown this. And another one, this finding suggests that low dose letrozole may be valuable alternative to GnRH antagonist with a lesion location serving as a clinical determinant of reproductive success in adenomyosis. Selective progesterone receptor modulators, SPRMs, there is roles where they active because they promise lesion level progesterone pathway modulation without profound hypoestrogenism. In practice, development of endometriosis has been constrained by safety concerns, regulatory caution, and an inconsistent path to long-term routine use. Is a potential advantage, target the progesterone axis more selectively. Problem encounter, endometriosis itself often exhibits progesterone resistance, limiting clean transition. Possibly less vasomotor burden than deep estrogen suppression. Hepatic and endometrial safety concerns altered confidence in the class. Appealing concept for chronic disease, oral GnRH antagonist reached clinic with a clear efficacy package. Part of this mention SPRMs as mechanically interesting, historically important, but not the current frontline innovation story. So emerging reaction beyond endocrine suppression, inflammation, immunity, cytokine signaling, macrophage phenotype, mast cell biology. Neurogenic pain targets, secondary nerve growth, neuromodulated pathways, central sensitization interfaces, and fibrosis angiogenesis, antifibrotic pathways, vascular remodeling, lesion microenvironment, and precision endocrine design, better ADVAC, partial suppression strategies, and biomarker-guided selection. In the pipeline are still early. For today's practice, oral antagonists remain the only major new drug class with broad real-world teaching relevance. How current guidance position newer drugs? Yesterday already have discussed this. Relagolase combination therapy, Relagolase have already marketed in the. This reflects the move towards the partial practical indication rather than keeping antagonists as purely rescue pharmacology. It should be effective, important, increasingly indicated, but patient selection and monitoring still matters. These are the monitoring contraindication checklist for all the things. First to check the pregnancy exclusion and contraception plane. White matters, these drugs are not for use during pregnancy. Symptom response can confuse cycle tracking. Enter the whole class of B1. Bone health baseline should be monitored. Prior low BMI, future risks of prolonged prior suppression changes recently. High dose illegalists, long course antagonists. Vasomotor tolerance and quality life. Symptom burden can drive disconnection even when pain improves. Enter class. Thromboembolic and estrogen contraindication. Fixed dose ADVAC regimens containing estrogen require extra care. Religiosity, any estrogen containing support. Liver, metabolic, and mood history. Routine endocrine-based chemistry still requires whole patient review, and the drug should be individualized. Choosing therapy by phenotype patient priorities. Young patient, first-line hormonal failure, dominant dysmenorrhea, reasonable emphasis, oral antagonist becomes factor two, especially if rapid reversible suppression is preferred. Mixed dysmenorrhea plus non-menstrual pain need longer horizon. Religiosity is conceptually strong because ADVAC is already indicated. Need to minimize hypoestrogen burden, partial suppression approaches or lower intensity regime deserve consideration. Deep infiltration disease with bowel and bladder symptoms of fibrosis do not overpromise medical therapy. Multidisciplinary review and surgery may still dominate. Immediate fertility goal, neosuppressive drives control pain, but do not solve the fertility pathway, plan accordingly. To answer it, never just which drug is best, it is the best for whom, over what duration, with what tolerance for hypoestrogenism. Practical treatment is already known to all. ICOG, I'm not going to the details. The newer drug in the pipeline is already FDA. This is Endo 205, is a E-peptide therapeutic drug that will act as a. Recently, the FDA has allowed for the clinical trial for the phase 1 trial. How it works? It works with the Endo 205. This targeted peptide therapeutic designed to specifically eliminate endometriosis lesions and reduce inflammation without altering hormone levels, potentially addressing the root cause rather than just symptoms. What is the target of the first trial? The treatment aims to eliminate all lesions within a short 3-month treatment course. Is there any time?
We are running short of time, sir.
Yeah. So I am skipping that case discussion is already arranged. So unanswered questions for the next 5 years. Can biomarkers identify who needs partial suppression versus deep suppression? Will add-back strategies allow safe multilayer treatment beyond current level limits? Can non-molar anti-inflammatory or antifibrotic agents break the link between efficacy and hypoesteronism? Will beta phenotypic separate lesion-driven pain from centrally sensitized pain early enough to avoid fetal escalation? The best future drug would reduce pain, inflammation, and fibrosis without the bone and vasomotor price of deep estrogen deprivation. So key take-home message: the major modern advance of oral and GNase antagonism with control over depth suppression. Elagolix proved the class. Relagolix CT proved long course fertility. Linagolix sharpened the precision suppression data. Bismuth benefit is often strongest. NMPP improves too, but pain phenotype still matters. Advac therapy is a design principle, not a sign of failure. Newer drugs are powerful tools, but surgery, fertility planning, and multimodal pain care remain essential. I'm not going to the details of it. Now for your information, for the research works, our brain signaling is that, just for your inquiry, this is the FNRI schemes. They talk about endometrial, the alpha, beta, and delta. These are the signals focused from our cortical zones. And we can find out that modules to early diagnosis. Well, we'll talk it later. This is not the place to talk. Thank you very much for your patient hearing.
Thank you very much, sir, for an informative talk on newer drugs in endometriosis. Thank you once again, all the speakers, for a PowerPoint session on endometriosis. Thank you, everybody.
Thank you, Chairperson Hemalata, for your nice compilation. And now it will be followed by a quick run of MCQs.
Yeah, ma'am. Jignesh, please run the quiz. And just explain how the quiz will be run. Jignesh, over to you. Jignesh, you have to tell how the quiz is going to be run to the audience.
Okay, just 1 minute. You can see this website. Here is the questions coming and here is the live. You have to answer in 30 seconds. The quiz is started now. Ma'am, you are in mute.
Yeah, the first question is, which of the following is the most accurate statement regarding long-term dynages therapy in endometriosis? It significantly reduces the BMD similar to GnRH analog. It maintains stable estradiol levels in low physiological range. It causes profound hypoestrogenism comparable to menopause. It is contraindicated for use beyond 6 months. No, tell me the correct answer we'll see in the end. Okay. The second question is, in which of the following clinical scenarios are aromatase inhibitors most apparently used? First line management in adolescent, refractory endometriosis not responding to conventional hormonal therapy, mild dysmenorrhea, responsive to NSAID, and routine use in all infertile patients with endometriosis. Next.
Oh,
See, don't show the answers, only after they finish. Okay, now 30 seconds are over means you go back to the second question and flash the correct answer. Go back to the second question. Back. Correct answer is yes.
the same way.
Next. What is the primary role of NSAID in medical management? Suppression of estrogen production, reduction of lesion size, inhibition of prostaglandin-mediated pain, and induction of amenorrhea. "30 seconds over. You can have the timer, yeah.
The timer is up.
Okay. So the correct answer is inhibition of prostaglandin-mediated pain. Next question. Compared to GnRH agonist, oral antagonist, elagolix and elagolix offer which key pharmacodynamic advantage? Permanent suppression of HPO axis, initial stimulation, flare effect of gonadotrophins, immediate suppression with dose-dependent partial estrogen suppression, and increased estrogen production. Correct answer is immediate suppression, dose dependent way. Okay. So this flare effect occurs only in agonist, not in antagonist. Next. Which of the following is most accurate statement regarding long-term dialysis therapy in endometriosis? Significantly reduces BMD similar to GnRH analogs. No, this is over. This is a repetition.
This is the repetition.
Yeah. Go to the next question. The correct answer is, you tell the correct answer here.
Oh, applicable.
B is the correct answer.
Okay. Next question. Which
Which
MRI finding is most characteristic of ovarian endometrioma? T2 hyperintensity with fat suppression, T1 hypointensity with T2 hyperintensity, T1 hyperintensity with T2 shading, diffuse restriction only.
sodium loss
The correct answer is?
আরে এটা এমনি বয়সের সাথে হতে পারে খাওয়াতে জাস্ট দেখো জলটা বেশি যতবার পায়খানা যাবে ততবার সে এক গ্লাস জল খাবে বাড়ছে কারণ সোডিয়াম বেরিয়ে গেলে ভীষণ লেথার্জি হয়ে পড়বে
T1 hypointensity. Dr. Babakaran has clearly mentioned how it will be. T1 shading and T2 shading, everything. Yes. T2 shading in endometriosis is due to acute hemorrhage, calcification, chronic repeated hemorrhage with high protein content and fat deposition.
স্যাচেট দিয়ে দেখো ইকোনম স্যাচেট দাও ঠিক আছে
Suranjan sir, please mute yourself. Suranjan sir, mute yourself.
সন্ধ্যাটা দাঁড়াতে হবে কেন হ্যাঁ আচ্ছা হতে পারে তুমি ইকোনম স্যাচেট দাও একটা মুখে দিয়ে দাও কিংবা জাস্ট গুলিয়ে সাথে সাথে খেতে হয় মুখে
Suranjan sir, mute yourself.
তিন চার
In T2 shading is chronic repeated hemorrhage. That is why you get the layering of the endometriosis. So you will get varying stages of blood at varying stages, the clotted blood at varying stages. Next. Which MRI feature suggests adenomyosis? Well-defined myometrial mass, hyperintense cyst in the ovary, junctional zone thickness greater than 12, and peripheral nodular enhancement. Correct answer is junctional zone thickness when it is greater than 12 mm. Next. Tiny T2 hyperintense focus with thickened junctional zone in adenomyosis represents fibrosis, calcification, dilated endometrial glands, and necrosis. Correct answer is dilated endometrial glands. Yes, next. Which feature helps differentiate endometrioma from hemorrhagic cyst in MRI? Hyperintensity, T1 hyperintensity, T2 shading, and persistent and follow-up, thin wall, absence of septation. Yes, correct answer is T2 shading with persistent on follow-up. Okay. Which dietary adjustment is most commonly recommended to reduce circulating estrogen levels in women with endometriosis? Increased red meat consumption, higher intake of processed carbohydrate, increased dietary fiber intake, avoid all green vegetables. The answer is increasing dietary fiber content. Next question. Pelvic floor physical therapy is specifically useful in endometriosis care to replace the need for diagnostic laparoscopy, relieve muscle tension and improve the mobility in pelvic organs, regulate the menstrual cycle hormonally, increased caffeine absorption. The answer is relieve the muscle tension and improve the mobility. Yes. Next question. Pelvic floor which psychological intervention focuses on changing the patterns to help manage emotional burden and chronic pelvic pain? Nutritional counseling, homeopathy, cognitive behavioral therapy, and ultrasound therapy. The correct answer is cognitive behavioral therapy. Next. 32-year-old woman has laparoscopically confirmed endometriosis with severe dysmenorrhea, deep dyspareunia, non-menstrual pelvic pain. She does not desire pregnancy for next 2 years. She previously had only partial relief with NSAID and combined OCPs. She wants oral option with a rapid onset and no flare phenomena. What is the most appropriate one? Continuous luprate without counseling, immediate IVF, tranexamic acid during menstruation, elagolix, letrozole monotherapy in natural cycle. Elagolix. Correct answer is because it doesn't have the flare effect, can be used long term. Yes, next. And partial estrogen suppression will be there. Clinician prescribes Elagolix combination therapy for a woman with moderate to severe endometriosis associated pain. Why may combination therapy is preferred over profound estrogen suppression alone? Completely eliminates the need for monitoring adverse effects, maintains estrogen at a sufficient level to reduce hypoestrogenic complications while preserving efficacy. It transforms a suppressive regime to a curative one. It increases the lesion vascularity to improve duct delivery. It stimulates ovulation and preserves fertility during treatment. Yes. Correct answer is maintains the estrogen level, optimum level without causing hypoestrogenism. Postgraduate trainee states both GnRH agonist and antagonist eventually lower estradiol, so they are clinically interchangeable. What is the best rebuttal? Antagonist can only act at the ovary, agonist only at the pituitary. Antagonist competitively block the receptors and avoid initial GnRH surge seen in an agonist. Agonist selectively suppresses FSH but not LH. Antagonists are injectables, whereas agonists are oral. And then antagonists never reduce BMD. Agonists never reduce BMD. Correct answer. Yes. 36-year-old woman continues to have symptoms despite prior ovarian suppression strategies. Our clinician discusses adding another aromatase inhibitors in a refractory setting. Which pathobiologic concept best supports this? Endometriotic lesions can generate local estrogen that sustains lesion survival. Endometriotic implants are unaffected by inflammatory mediators. The disease is caused solely by excess prolactin. Disease endometriosis is entirely progesterone independent. Ovarian estrogen plays no role once the lesions are established. Correct answer is each endometriotic tissue is capable of producing its own aromatase is there. It can produce their own estrogens. Next. A patient doing well on oral antagonist asks whether she can remain on it indefinitely because her symptoms have improved substantially. What is the best response? Long-term treatment is limited mainly by cumulative nephrotoxicity. Long-term treatment is impossible because the drugs lose all effect after 3 months. Long-term treatment is avoided because they directly induce endometrial carcinoma. Long-term treatment is limited by concern for hypoestrogenic adverse effect, especially bone loss. Long-term treatment is contraindicated because they cause universal infertility. Yes, because each one has got its own limitation. Then 19-year woman treated with newer hormonal suppressive therapy shows symptomatic improvement, but still reports chronic pelvic pain, disproportionate imaging findings. Which mechanism best explains why the pain persisted? So chronic pelvic pain and endometriosis may improve peripheral and central sensitization in addition to lesion burden. Pain always correlates linearly with the lesion size. Imaging always detects full burden of activities. Endometriosis pain occurs only during menstruation and hormonal therapy cannot reduce inflammatory. So the answer is A. Chronic pelvic pain in endometriosis may involve peripheral and central sensitization. That is the reason why even after surgery, the patient continues to have pain. The last question is which patient scenario most strongly supports considering aromatase inhibitor? A patient with mild cyclical discomfort, fully controlled with NSAID, patient seeking immediate spontaneous conception this month. A patient who has complained is menorrhagia from large fibroid uterus, patient with refractory symptoms after prior hormonal therapy, especially under specialist care, patient with acute ectopic pregnancy. Answer is B. Okay. So I think we are coming to the end of this. So I thank you so much, all the faculties, chairpersons, for your kind participation. And more than that, all the delegates who have been there patiently listening for more than 2.5 hours. And I thank Olympic for having given us the platform. Thank you so much. Harshini, you want to add up anything?
Ma'am, thank you so much, ma'am, for the extreme vast of information. Thanks a lot for all the speakers.
Harshini, you start collecting all the MCQs. We can
Yes.
make it as a booklet, either as an ebook or a booklet, and we can distribute during the conference.
Sure, ma'am.
What, sir? I think that will be a good suggestion, no? Handbook on MCQs in endometriosis.
Thank you, Ramani.
Thank you, sir.
So. Keep up doing all.
Thank you, sir. Let us come to the end of the program.
Thank you very much.
I close. Okay.